Welcome, everyone. Thank you so much for joining us today at the 10th Annual Patients Redefining the Future of Healthcare in Canada Summit. My name is Antonella. I'm the CEO of Psoriasis Canada and a very proud co-host. And it's my honor to begin our event with a land acknowledgement. We'd like to begin today by acknowledging that although we're meeting in a virtual space, we honor the lands we each call home. From coast to coast to coast, we recognize the ancestral and unceded territories of all Inuit, Métis, and First Nations peoples across this country. I'm joining you from Toronto, the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. I also acknowledge that Toronto is home to many diverse First Nations, Inuit, and Métis communities, and that this land is covered by Treaty 13 with the Mississaugas of the Credit. As we get started here today, I invite you all to reflect on your own land acknowledgement and to share it in the chat so that we can all recognize the many places that we're joining from today. With that, it's my honor to turn it over to Sharon Clark to get us started for the day today.
Good morning, everyone. On behalf of the organizers of the Patient Redefining the Future of Healthcare in Canada Summit, Save Your Skin Foundation, Psoriasis Canada, and Kyosu Consulting, we warmly welcome you and thank you for joining us today. The summit is in its 10th year, a milestone celebration for us, and one which we would not have imagined reaching when we began this event 10 years ago. We know that the healthcare landscape has changed profoundly over this decade. Many of the same barriers and challenges to optimum healthcare for all, however, remain, and some would say increased in some areas. Aligning health, social, and economic policies and practices continues to be essential for the advancement to a society where there is a framework that provides equitable health outcomes across this country for everyone. So over the years, the summit has been a national platform for a number of interested parties to come together to discuss the challenges to achieve this aim, learning, educating, and sharing experiences from each other. From this, we build on our action plan to be part of the solutions in a number of areas that impact health outcomes, including those that are often referred to as social determinants of health. We have had robust discussions at the summit about ways to develop holistic, patient-led health outcomes based on value-based healthcare, integrated models of care, and ways to mitigate health inequities that require continued collaboration and cooperation to resolve. So to that end, we have talked about housing, especially for equity-deserving groups, including structurally underserved communities, about poverty, anti-Black and Black racism, newcomers and refugees, the toxic drug supply, responses to substance use, and the desperate need for a pan-Canadian interoperable health data structure, among other important issues. So throughout the years, we have been able to highlight specific First Nations, Inuit, and Métis health as an integral part of the summit. So we will continue these rich discussions this year. Thank you. Over to you, Kath.
Next slide, please. Over the years, we've been fortunate to have sponsors that have recognized our vision and aims. We want to thank our sponsors for this year's event, Amgen, Johnson & Johnson, and the Canadian Institute for Health Information. We also thank Innovative Medicines Canada for supporting the working groups of the summit. This year was, is, and always will be Louise Binder's vision. As an intrepid leader, courageous advocate, and thoughtful visionary, Louise has created a space through this summit for advocates and allies to come together across diseases and disabilities to re-envision and recreate healthcare in Canada from the ground up. She is a leader who cares deeply about working together to create change in healthcare that is meaningful and lasting, and that patients 10 years from now and beyond can feel seen in and be proud of. Her years of experience motivated her to create this unique summit to move beyond sharing information about urgent issues affecting patients, caregivers, and people across Canada, in order to emphasize the opportunities and motivate meaningful, real-world action. On behalf of the Summit Committee and our Summit community over the years, thank you, Louise, for bringing us together. So before diving into this year's thought-provoking agenda and hear our amazing speakers, we want to commemorate the 10th anniversary by sharing some of the highlights from previous summits. It was a very difficult choice about which of the many of them to include, but here are only a few. Video, please.
Patients and citizens will be able to say what they need to keep people well, physically, mentally, emotionally, and spiritually.
The room and see marginalized or different identities that we see here. LGBTQ, trans, Black, Indigenous, they are not part of this conversation.
Mental models signal how to act from a social norm sort of thing, but also how to act when we consume information. So bias tends to drive behavior in the absence of an intervention. Changing underlying mental models changes belief in bias.
We're not basing investments on how the system's going to be better. We're not bringing that forward into how we hold people accountable.
Everyone wants to fix healthcare until you try to change something.
Healthcare system that puts their needs first. Sustainable and accessible for everyone.
We need to recognize our populations are changing. We used to have this idea that we were one big nation, but there's lots of different groups.
And across areas, we should be doing that always with this focus about how we're increasing knowledge.
Targeting what matters to the person, how much does it cost, not for one intervention, but the entire trajectory. We should be measuring value and using those measures to make better decisions.
Building trust, which involves transparency, inclusiveness, more tables, is a critical step forward.
Everything in healthcare should be called value.
We assumed safety was a priority for the system, that the system would do anything to make safe care possible. We know that's not necessarily the truth. It amazes me the number of times we talk about initiatives in healthcare and it's not grounded in the need.
Historical traumas that were really starting to come in the 1960s. We were sent away for school at a very young age. I was 10 when I was sent away for school. 2 years with a family in Nova Scotia, 3 years in a residential setting where 200 Inuit children were sent from Nunavut to Churchill, Manitoba.
So with the housing first and all, and the prevention work, Helsinki, like I said, has more or less ended street homelessness.
I used to assume I had no issues being discriminated against. Then I found out how wrong I was. My gender impacted my health services.
And being stereotyped not by the way I looked or my clothing or how I presented myself, I was stereotyped and labeled as, you know, an alcoholic or a drug user based on when my provider asked me what my nationality was.
I struggled to pay my rent with minimum wages. After 1 month notice, I still couldn't find a cheaper place and was pushed into the street. I became homeless with a full-time job.
Having been sent away on a ship, being hospitalized for an extended period of time was re-traumatizing for my mom.
Rough or unsheltered is up 100%. The raw reality is that being unhoused is by definition, meaning that at some point you will deal with seriously ill health in Canada. We have a home healthcare system unable to deliver care for people without homes.
Triggers, well, what kind of triggers am I talking about? These are smells in a hospital. They're the noises. They're procedures. There's needles. There's being given a pill. Actually taking the pill when your experience has been that those things were forced on you. You're going to associate that intervention, that medical intervention, nursing intervention with pain.
300 years of colonization and ongoing trauma, unhealthy living environments due to disempowered communities, due to colonized communities, puts Indigenous people at a higher risk of being infected.
Healthcare professionals and administrators must reflect the diverse communities that they serve.
This will help break down cultural and linguistic barriers and promote trust.
In my experience in adult literacy, low literacy levels affect health. You can't read a prescription. You can miss vital information about medication. A woman accidentally took her husband's medications and wound up in a coma. I find that information given by pharmacists tends to be written at or above a grade 8 level. But 48% of Canadian adults have difficulty reading at that level.
This, always leaves the question of, can we afford what we're doing, or can we afford done house? And I think the argument would be we can't afford not to do this at scale. We cannot afford the status quo. Someone staying a month at the hospital they work at is over $30,000. The provincial jail costs, which my dear friend Lana Fredo calls the de facto mental health system, because people have nowhere else to go and end up in the justice system, especially for racialized populations. The provincial jail cost is close to $15,000. Sheltering now has come down a bit to probably $7,000 since the pandemic, but it's still almost double the cost for supportive housing.
Keeping people in poverty, using your voices as patient groups to advocate and bring those stories forward.
Homelessness, because we know that the health outcomes for people will get significantly worse the more that they are within homelessness. But we know also as well for lots of other folks for different reasons, different health reasons, that supportive housing is something that is vitally needed, but unfortunately quite absent.
The Indigenous population is highly diverse in identities, experience, and connection to culture. It's essential we provide culturally safe, trauma-informed care.
Data should follow the patient so we can make better decisions.
There and actually helped advance some work around the patient's health declaration of health data rights. So that was, which I was utterly thrilled to see being published earlier on this year, because I think that is really important for patients and persons in Canada to really make it clear what your expectations are for your health data in the context of its use.
A lot of hospitals have more huddles, but they spend far less time in those huddles because they're not running around trying to get information. They're spending that time using the information on the screens, making decisions, not just collecting data to then try and make a decision.
We need coordinated efforts sustained across all Canadian jurisdictions. None of us can be left behind in the data dark ages of paper records, missed voicemails, and the infamous fax machines.
Our collective health data is aggregated to figure out the health system and form the basis for policy and practices.
Building trust, which involves transparency, inclusiveness, more tables, is a critical step forward.
As patients, advocates, and allies, we can redefine the future of healthcare in Canada. It is important to be part of the conversation for our children and grandchildren and next generations.
There's value of engaging patients. You want to reduce rates, costs, improve quality. There's a lot more recent work that really talks.
And listen to the cultural cues, understand people's circumstances, and we move on with the people that we serve together, co-creating a treatment plan or any action plan that change their lives.
Many of us were here 15 years ago when the talk was about a national pharmaceutical strategy, real-world safety, special access program. We had an Office of Consumer and Public Involvement that doesn't exist anymore. Why did they fall apart?
We need a learning health ecosystem that works for everyone. To get there, we need patient engagement.
The challenge of patient engagement is to include diverse perspectives. Our systems have been built upon structures of oppression. Who we are, the place we occupy, our ability to access resources, we created our society to be unequal. And when we drive patient engagement through these systems, we reinforce those structures.
We're focusing on the outcomes that matter to those patients. So the African proverb says, if you want to go fast, go alone, but if you want to go further, go together.
Individuals that we serve. So this approach goes beyond the concept of physical health or simply the absence of disease. It is about nurturing the whole person and recognizing that true health involves balance across all dimensions of life. So our model is firmly rooted in a population's needs-based approach to healthcare planning, and we incorporate Indigenous-informed evaluation methods and scaling leading practices to achieve excellence in Indigenous health.
In the need for teamwork in healthcare in order to deliver safe care. And then in order to have teamwork be possible, we need access to everybody on the care team needs access to information and the ability to communicate between the care team.
So we're working with several provinces to get initiatives going around diagnosis and speeding up diagnosis through navigation, dedicated pathways, or dedicated clinics for that, as well as things like hub and spoke models, where care could actually be given in smaller centers closer to home, and not all have to necessarily be brought into a specialized center.
If we don't have an integrated system, we don't create a place where people can see those payoffs, and will continue to underinvest. We need to look at investment across the continuum, integrating that continuum.
Without mental health, there can be no true physical health.
Technology does have the potential to increase access to care and can be quite positive. But we use remote presence that I was talking about. What it meant was that the patient was talking directly with the specialist or with the doctor, and that the nurse or the doctor listening in and being able to hear directly from this provider makes a big difference.
So when I think about culturally responsive healthcare, and making it, how we make it a reality for all Canadians, it's an individual responsibility to make the shifts, but there's also a collective responsibility to make the shifts.
We see the way forward as one where we have decision-making tables that are inclusionary, where we have an ecosystem for equitable patient engagement, the cornerstone of a learning health system.
Okay, good morning. Good morning, everyone. It's my pleasure and my honor to introduce our keynote speaker. Our keynote speaker is Dr. Cassandra Opikiku-Wajenta, and she's a proud member of Canoe Lake First Nation, Cree First Nation in Meadow Lake, Saskatchewan. Cassandra comes from an interdisciplinary background that is driven by practical solutions in problem-driven areas. She finished the top of her class in 2009 with a BA in journalism and a certificate in Indigenous communication arts, which is INCA. During her studies, she worked in numerous media outlets, such as CBC Saskatchewan and Global TV in Alberta, before completing her Master of Public Administration in 2012 and her PhD in Public Policy in 2022. So in 2016, she was a visiting scholar at the University of Hawaii, John A. Burns School of Medicine, Department of Native Hawaiian Health, while working in a community-based research on Native Hawaiian healthcare systems. Most recently, she was the director of the Indigenous Peoples Health Research Center at the First Nations University of Canada. Dr. Opikiku-Wajenta has over 15 years of experience building relationships with Indigenous communities, both locally and internationally, and has helped IPHRC contribute over $20 million in Indigenous health research funding in Saskatchewan. She is also a former co-chair of the University of Regina Ethics Board and is an appointed member of the Public Health Agency of Canada's Ethics Consultative Group, which is PHECG, providing high-level ethics guidance to federal departments on emerging public health issues such as the COVID pandemic. And lastly, her husband, Justin Wajenta, is a member of the Standing Buffalo Dakota Nation, and together they share 4 wild children and numerous animals. So over to you, Cassandra.
Perfect. Thank you so much for that introduction, Sharon. So Today's presentation is called Intimate with Strangers. And as I was thinking of a title, I was trying to think of what healthcare experiences can feel like for us as patients. And we really are sharing some of our most vulnerable moments with people we've never met before. So in my case, one of those moments that I wanted to discuss today was my story of childbirth, trauma, and the healthcare system. Next slide. So my discussion this morning was going to be a lot about statistics and health facts. And ultimately, that was not what I felt called to do. And it's interesting because as we looked at the retrospective video, you guys actually heard a lot about Indigenous health. So it's a very nice setup for what I'm going to talk about today. But I'll be discussing topics such as medical trauma, birth trauma, birthing itself. So if any, and intergenerational trauma from residential schools. So if any of those topics are really sensitive for you, or it wouldn't feel good for you to listen to this presentation, then I will take no offense if you choose to just tune out my talk today. If you are going to stay, then it's really important that you think about ways you can take care of yourself when we're talking about these difficult topics. So what I mean by an accessibility check is just make sure you're comfortable, make sure you can hear properly, make sure you can see properly. Grab a coffee if you need to be comfortable. I know it can be long listening to online presentations, so do what you need to do. If you find the topics a little bit too much at various points, take a break whenever you want. If you need to go up and go for a walk, get some fresh air, take a bathroom break, grab refreshments, do it. Take a deep breath or even talk to someone. And those are things to keep in mind after the presentation today as well. Next slide. So Sharon, was very kind and introduced me. I think it's important to always start with where you are from, because in Indigenous context, when we meet each other, we don't ask, what do you do? We ask where you are from. And we're trying to place you and your connections and understand how we may or may not relate to one another. And so I include these details here so that you can understand what the limitations are of what I can speak to today and my perspective. So I grew up in Northwest Saskatchewan in Meadow Lake. If you're familiar with that area, the families that I come from are the Opikikyu family of Canoe Lake, the Bouvier family of Isla Cross, and the Brooks and Arnold families of Meadow Lake. I am literally the Saskatchewan story. On my mom's white settler side, it's literally people who came on a boat from England and broke land here near the Beaver River near Meadow Lake. And on my dad's side, it's First Nations Cree people who have been here since time immemorial. So the whole Saskatchewan story right here with me. I have 4 biological children, 5, 8, 9, and 10. And then I have an 18-year-old niece that we care for, who's very special in our life. I'm an intergenerational survivor of residential schools, which I'll talk about, and I live in Fort Qu'Appelle, Saskatchewan. I'm a bit of a weird duck when it comes to my research background. I have never taken an Indigenous health course in my life, and yet I teach them. And my background is very interdisciplinary, so I really come at things from a policy perspective and a storytelling perspective, and that's what we're going to do today is tell some stories. Next slide. So just to show you visually for those of you joining from all over the place where I'm from, the 2 blue arrows on the map, the top one in northern Saskatchewan is where Canoe Lake Cree First Nation is, my home community. And the bottom blue arrow is where I'm talking to you today from, Fort Qu'Appelle, Saskatchewan, which is near my husband's community of Standing Buffalo Dakota Nation. If you look at the map with all the colors, I'm from Treaty 10 territory, grew up on Treaty 6 territory, which is now where I also work at the University of Saskatchewan. And now I live in Treaty 4 territory in Southeast Saskatchewan. So varied experience here in this province. Next slide. So any discussion of Indigenous health needs to start with setting the context. And the context for Indigenous health is that we carry trauma. And a lot of the origin of our trauma as First Nations people in particular is, of course, from colonization in general, but residential schools, which forcefully removed children from their homes and families. And so in my family, that was my grandfather who attended residential school. He's the photo on the bottom left. And that's actually me that he's kissing in the photo as a toddler. So my grandfather, Louis O'Picaque, went to Beauval Indian Residential School. He was sent there when he was 6, and he spent most of his childhood there. Some of the things he was subject to at residential school, and we don't know this because he didn't tell us. We know this from stories from the school. And that was part of his way of protecting us, was to not share those stories and relive that trauma. But we know that at Beauval Indian Residential School, students experienced physical abuse, sexual abuse, domestic violence, neglect. When they came out, we saw substance abuse, loss of traditions, loss of language, and loss of stories. So my grandfather was subject to many of those things at residential school. And then he passed down many of those harms to my dad. And he's the photo on the left-hand side with the baby. That's him with my daughter, Mioswin. And so my dad survived all of the things on that list. He grew up in a home with domestic violence, substance abuse. He himself suffered from substance abuse to cope with that trauma. And so you can see in my family, that's the origin of our trauma. And it goes from my grandfather to my dad to me to our children. And what we're hoping for is that with each generation, that trauma is dissipating and we are healing. And thankfully in my family, I think we've somewhat turned a corner and we have started that process of healing. Next photo, or next slide. So this is actually a picture from the site of Beauval Indian Residential School, and the yellow arrow is pointing to a name. It's Alex O'Picaque. He was aged 8. There was a fire at Beauval Indian Residential School, and many in the boys' wing, and many children didn't survive. And so my grandfather's brother was one of those who passed away in the fire. So we actually visited this memorial this summer. Next slide. So why does this matter? It matters because we have blood memory. We carry memory in our DNA, and blood memory is this belief that we carry the wisdom of our ancestors and our culture in the blood. And there's research around this idea now, and it's called epigenetics. And much of the research is done in terms of how intergenerational trauma is carried in our genetics for up to 4 or more generations. So we carry this deep inside ourselves, even if we're not the person who attended residential school. Next slide. So a new generation is being born every day, and I was expecting my 4th child in March of 2020. And this is where I thought I was going to give birth. I thought I was going to give birth in this beautiful birthing suite at All Nations Healing Hospital in Fort Qu'Appelle, which is actually a First Nations owned and operated hospital that serves both Indigenous and non-Indigenous people. So this is where I thought I was going to give birth to my daughter. Next slide. And I included this artwork because this was the experience that I was hoping for, being in Indigenous space, following Indigenous birthing practices and feeling supported and empowered by both my partner and other people with birthing expertise. Next slide. Because of complications related to my labor, I ended up needing to go to the Regina General Hospital. So this is the labor and birth unit. It's up on the 2nd floor, I believe. And so you have to come in the main entry, walk down a really long hallway, take an elevator, and then walk again to get to this space. So it's actually a couple minutes from the front door to labor and birth. Next slide. And I had given birth there previously, so I sort of knew what to expect. This was very similar to one of the spaces I gave birth in 2016 for my son Mohican. And so you can see very different kind of space from what I had planned on birthing in, a little bit more cold, a little bit more medical, a little less comfortable. Next slide. And so I thought that was going to be it. That would be the room that I birthed in, less than an ideal scenario. However, parking is an issue at this hospital. And so my husband dropped me off at the front doors to go find a parking space so that I wouldn't have to waddle. And so he left me. And in a period of about 5 minutes from when he left me to when he came back, I gave birth. And in that photo, right inside those doors is the main admissions entry for the entire hospital. So you can find people milling around a Robin's Donuts, the admissions desk. There's 40 people waiting in a waiting room. The process is you take a number, you sit, and then you go register, and then they send you up to labor and delivery. I felt like I was giving birth. I could feel it happening. And I took a number and sat down and realized this is happening much faster than I expected. They had a man already at registration desk. So I took my number, I kind of like hovered behind the guy in the chair. And my goal was to just tell the women at the front desk, look, my baby is coming right now. I'm going to go straight upstairs without registering, okay? I stayed very calm, perhaps too calm, because after they made me wait, I spoke to them and said, I'm going to go straight up. And they said, no, just sit and register. And I said, I can't. My baby's head is out. And they said, what are you talking about? And I said, my baby's head is out. I'm giving birth right now. I need to go straight up. And instead of talking to me, they spoke to each other. And I'll never forget how they went back and forth talking about this most intimate moment of my life, saying, what did she say? She said she's having a baby. She said the head is out. What are we supposed to do? I don't know. Nobody came around the desk to help me. And the 40 people in the waiting room whispered to each other while I birthed my daughter right there on the floor by myself. In fact, the birth happened so quickly, all I could think to do was throw down my birth records in a brown envelope to try to cushion her fall so she wouldn't fall on the dirty floor. But my first vision of my daughter was this brand new baby covered in blood, holding onto an umbilical cord by itself on the floor. And I genuinely didn't believe she was alive. The first person to actually hold my baby was an amazing woman who just happened to be walking into the hospital that day, saw what happened, came up to me, asked consent, and said, is it okay if I pick up your baby for you? And I said, yes. And so she picked her up and handed her to me. And then that lady left, went on with her day. Meanwhile, none of the 40 people stood up to help me or check on me and the baby. And just like those women behind the desk, I could hear them all whispering to each other saying, she just had a baby. Did she just have a baby? Look at what just happened over there. But nobody helped. So that was the birth that I ended up having. And it was not at all what I planned. It wasn't private. It wasn't respectful. It wasn't the intimate scenario that I had hoped for. So I literally gave birth with strangers. Next slide. So this artwork really represents what that patient experience felt like for me. Why was I unlucky? It says on here, worst nightmare, failed. So immediately after my birth, everyone said, wow, you are superwoman. You threw your records down. You birthed your baby. You carried her. I carried her up to the second floor. You're so incredibly strong. But that was not how I was feeling on the inside. I was feeling what I now understand was post-traumatic stress disorder. And I felt guilt and I felt shame and I felt embarrassed. Next slide. And that's not uncommon for women who give birth. This is the birth trauma tree, and it can lead to a diagnosis of PTSD if the trauma is significant enough for somebody. And so I experienced many of those roots at the bottom that cause the trauma. So medical neglect, medical interventions. I had my placenta forcefully removed out of me by a doctor when I got to the second floor. I literally tried to rip their hands from inside of me to the point where they had to somewhat sedate me. And they proceeded to do that without my active consent. So I experienced a lot of trauma as a result of this birth, and I experienced a lot of these things after the fact: insomnia, depression, anxiety, fear, flashbacks, etc. Next slide. So to summarize with that experience, I felt unheard. Literally, I asked for help and no one responded. I felt unseen. I watched while the healthcare providers spoke to each other instead of me. I felt judged. I felt unsafe. I felt incredibly alone despite all the people around me. I was embarrassed, I was shocked, and I felt violated. And the artwork on the right side here is actually AI generated when I asked for artwork of someone who had experienced trauma. This is what it created, and it felt very applicable to me. Next slide. I did everything right that day. As a patient, I was washed, I was dressed nicely, I was shaved, I did my hair, I spoke calmly, I was borderline professional, I tried not to be a bother, I waited for my turn, and ultimately I realized I tried to make up for what felt like my Indianness. And I've gone into lots of healthcare settings, and other Indigenous people do this as well, where we know we're going to be stereotyped. We know someone is going to express racism. We know we're not in a safe place as soon as we go into the healthcare system. And so we try to bolster ourselves and speak nicely and not be a bother and not ask for too much and look nice. Like, no birthing woman should have to consider those things when you're in the middle of contractions. But I did all of this prep that day. And it's sad that I felt like I needed to make up for my Indianness to have a certain kind of patient experience. Next slide. And so here's a picture the day after I gave birth to my daughter, Kamamina, which means butterfly in Dakota. We call her Kimmy. And in this picture, I was feeling, so attached to her. I wouldn't leave her alone for a minute, which I now understand was the PTSD, but I didn't trust anyone with her. And while it looks like I'm giving her a loving look, my eyes are actually really puffy in this photo because I've spent the last 24 hours crying, and I'm suicidal actually in this photo, trying to cope with the medical trauma that I had experienced and feeling guilt over not being able to give my daughter a safe birthing experience. Next photo or slide. It is a photo. Here's my daughter 2 weeks later. We took beautiful pictures of her on this star quilt a family member gifted us. And the birth of my daughter, even in my darkest time, reminded me that we can find beauty in the ugliest of moments and we can find meaning. Next slide. And so I got the help that I needed. I went to counseling. I started medications. I actually approached a conversation with the hospital. I consulted with lawyers. I did everything that I could to try to engage in some positive healing practices for me and find a good way to get through this. Next slide. And what we really want to do is provide patient experiences that are not like what I experienced. We want patient experiences that are supportive, respectful, caring, culturally safe, holistic, self-determining. We should have agency in our healthcare experiences. We should get to make decisions. We should make choices. We need to have a voice. And of course, we should have patient experiences that are private, and even more so than that, dignified. You are allowed to maintain your dignity as a person, even if you are in the middle of a healthcare crisis. And we need to remember that as providers and healthcare professionals. Next slide. And so, thankfully, spaces are being created to provide holistic, culturally safe, respectful, dignified care. And so what's actually in this photo is All Nations Healing Hospital. This is an exterior photo of the hospital that I originally wanted to give birth in with my midwife. And when this hospital was being created, they had to choose between a dialysis unit and a women's health center to start. And if they went with a deficits-based approach, they would have said, let's build the diabetic health center, because we know we have so many people in our community suffering from diabetes. And ultimately, they spoke to knowledge keepers who said, yes, that's really bad in our community, but we want to think bigger. We want to think upstream. And the heart of our community are the future generations, our children. And to take care of them, we need to take care of our mothers. And so they actually went ahead with the Women's Health Center first, and then created the Diabetic Center afterwards. So I was lucky enough to get treatment at that Women's Health Center for most of my prenatal care. And what's interesting is it serves both Indigenous and non-Indigenous people in the Fort Qu'Appelle area. And originally, there was some resistance to having a First Nations owned and operated hospital. But now, some of their biggest detractors are their biggest supporters. And this hospital is seen as a jewel in the crown of our community by both Indigenous and non-Indigenous people. Next slide. And these are not just healthcare spaces, they're sacred spaces for healing, because we as Indigenous people are really taking this back into our own hands. And to some extent, we find a lot more success with that rather than just indigenizing existing systems, really by taking them back to their origins and trying to find a way to decolonize and create space for Indigenous ways of healing. And so I show the birthing suite again because in more detail, there's Indigenous art, there's plants, there's lamps, there's candles, there's a beautiful birthing tub, and those 3 windows have this amazing view of the Fort Qu'Appelle Valley. It literally feels like a space for healing and celebrating birth as opposed to a medical procedure, which is really the experience we want to offer mothers and birthing people. Next slide. So why does this matter, and why do I highlight All Nations Healing Hospital? Because these are what I call dang good ideas. They're Indigenous concepts and values related to health, such as balance, holism, person-centered care, having roles for family and community, and respect for our traditional knowledge from knowledge keepers, and so much more. We're returning things like birthing, elders care, and even children experience foster care back to our communities, and we're demanding leadership positions. And that's really important because we know grassroots change comes a lot quicker if you have a champion at the top of that work. And we're demanding, not requesting, that cultural safety be a required part of this conversation. And cultural safety is this idea, quite simply, that I shouldn't have to erase or compete with my Indianness when I come into a healthcare setting. It should be welcomed and supported and seen. And even more than that, celebrated and made a part of my care. Next slide. And surprise, guess what? Non-Indigenous people prefer this kind of care too. This is a ceremonial room at All Nations Healing Hospital that patients can access. You can do pipe ceremonies, you can do prayers, you can do smudging. It's open to both Indigenous and non-Indigenous people. They have a traditional medicine room. They have traditional medicine people combined with doctors to provide both types of care, Indigenous and Western. And so what we see in Fort Qu'Appelle is that not only does this meet the needs of our Indigenous population, it's meeting the needs of our non-Indigenous population as well. So these ideas go beyond Indigenous communities to just creating better care for all. Next slide. And I mention this because I'm a policy theorist. And so often people throw around like, we can't do this because of policy. Let's go see what the policy says. The policy limits us to this. Policy is not the end of a conversation. It is the beginning. Policy, quite like generally defined, is a group of actors with the authority to make decisions on behalf of a larger group for their benefit. Or, in other words, it's a certain decision made at a certain point in time based on certain information by certain people. And so if any of those things change, the timing, the information, the people, then you need to revisit that decision. And so through my birth with Kimmy, some of the policy changes that happened were birthing people no longer need to wait in that public area to register. They changed that policy. Birthing people can go straight up to labor and delivery, which makes a lot of sense. It's too bad that what happened to me had to happen before that policy was changed. It was reiterated that the number one rule of a birthing person is to ensure that they are never alone. And interestingly enough, one of the reasons those women didn't come around from the admissions desk to help me on the other side deliver Kimmy was because policy at the hospital says they're not allowed to. Even though they're dealing with sick and injured and birthing people every moment, they are not actually allowed to go behind their glass at the registration desk and come help. That's a policy decision that needs to be revisited. Next slide. So together we can make change. We can change policies, we can advocate, we can team up with others, we can seek supportive care. If you have the ability to shop around for a doctor that makes you comfortable, or a healthcare provider or a nurse practitioner, it is a privilege, but use it. We can get mad. Sometimes getting mad is how we get things done, and we can channel that anger to really healthy ways. I know that that was a big part of my healing process. And if I had skipped the getting mad part, I wouldn't have been able to get to the forgiveness part. We can share, we can create leaders, and we can also ask for help. Next slide. And still another generation is being born every day. The photo on the left is me as a baby, and the photo on the right is my daughter, Kamamina, who ended up being healthy and fine, and by some miracle, basically saved her own life with how she delivered herself. And when I actually asked my daughter about our birth story, which of course she has no memory of, she likes to tell it. I tell it as this traumatic thing you heard today. My daughter tells it as, Mommy, I was just tired of being inside of there, so I jumped out of you. So that's her version of the birth story, which is very different than my version. But it'll be really interesting to actually share this with her one day when she can understand. Next slide. So we are healing, we are reclaiming. The photo on the left is my oldest daughter, Wakenya, at the Beauval Indian Residential School grounds. We took her there this summer. And the reason that there's the red tape is because this is actually where a lot of the missing graves are. They're searching, and there's very shallow graves, likely dug by children attending the school themselves, for all these missing children who never went home. And this daughter actually carries the middle name Louis after my grandfather who attended this school. So full circle moment for us to go back to that space and reclaim it and create new ripples for our family. So we are healing, we are reclaiming. Next slide. And we are here. We are here. We are the fastest growing population. We are the youngest population. We are doing all of that work together, sometimes on our own, sometimes despite major challenges. This photo is a photo of me with my dad and Kimmy, and the person I am in this photo about a year or two later from that original experience, she wants to live life. She's much more involved in her healing. She's grateful for the experience that she went through. And so just keeping that in mind, that as Indigenous people, we are here and we are demanding to be seen and to be heard. Next slide. So in the way as our knowledge keepers say, please take what you want from today and leave the rest. If there's something that sits well with you and is powerful, take that, sit with that, think about it more, digest it more. But if there's something that doesn't make you feel good or makes you uncomfortable today or triggers you, leave it in this space. Take a deep breath and leave it here today, and that's totally okay, because I want you to be okay after this presentation as well. So thank you very much for taking the time today. Thank you so much to the organizers for this invite. Thank you so much for me allowing to share about Indigenous healthcare in Canada through a story versus a statistic. So thank you.
Hi, thank you, Cassandra. That was absolutely awesome and very impactful. And I can just go on, but I would like to hear from some of the questions that are coming forth from our team. Thank you so much. That was just awesome. And I love that you also showed us what's possible and some of the processes that you went through. It's just awesome. Thank you. So we have some questions. We have one question here. If I am non-Indigenous, can I have smudging during my delivery?
Absolutely. Culturally, you can. Smudging is utilizing sweetgrass or sage, something of that nature, as you're probably aware, to sort of purify and pray and get yourself centered. So it absolutely has a role in birthing. The trick will be finding a facility that will allow you to do it. Some have really good policies around this, some don't, but absolutely you can take advantage of that as a non-Indigenous person. And it's great if you can find an Indigenous person to sort of explain the meaning behind that for you as well, so you understand it. But absolutely you could.
Awesome. Thank you. And here's another question. How can First Nations owned health services like All Nations Hospital be scaled to become the norm across Turtle Island?
That's a
huge
great question. That's a great question. I think one big part, just practically, is the federal and provincial governments need to work together, especially for First Nations people right now. Those are two very different health systems from when you're accessing care on reserve to when you're going to an urban center. There's even issues around just sharing data. So I think we need the federal and provincial governments to work together and realize that Indigenous healthcare is not just a federal area of concern, it's a provincial area as well. And even All Nations still struggles with that, getting the Saskatchewan Health Authority talking with the federal government. So I think that's a big part. I think the other part is you have to be really bold. All Nations was bold. They had the money, part of the money, they had the vision, and they said, if we build it, they will come. So you have to really have some visionary leaders within your system who are willing to go to the mat for ideas like this. Yeah.
Thank you. Here's another comment. Amazing and very moving presentation. When I gave birth and arrived at the hospital, there was no one at reception at all, and there was a sign noting to call a phone number to register. My water had broken, had filled my shoes, and no one answered the phone. Things need to change.
100%. I'm so sorry to hear that that's how you were received. That's absolutely not okay. When I share my story, guaranteed there's at least one other person in the room who has a similar birth story. So I'm so sorry that that happened to you, and thank you for sharing. Interestingly, when you talk about your water broke and filled your shoes, I had the same thing. So I have those shoes here still. I've never thrown them away. I've kept them because they're part of that very vivid memory for me. So thank you so much for sharing that. And yeah, sadly, these are too common of stories.
Okay, thank you. Also, another question, when you entered into the process to make some changes with the hospital, how difficult was that? Like, how did you do that?
It was pretty much impossible, I'll be honest. They got rid of the camera footage, so I didn't have that to refer to, which would have been helpful. They weren't interested in having a conversation with me, even when we reached out. So we pursued a legal path until at one point I realized, it was so expensive. I was $20,000 into the legal process and I was nowhere near the end. So I sort of came to the realization beyond the financial implications that these were just people behind these policies, and that I could offer forgiveness and acceptance of what had happened to me without seeking restitution. Interestingly, the reason the policies changed was because the story was so infamous, it made it back to their advisory group for labor and delivery almost immediately. And two of the doulas that I was utilizing to support my birth, one of them actually sits on that advisory circle. So I know it happened from me and Kamamana, but it happened in a very roundabout way of decision makers being at the table who cared and who voiced that we need to change this policy. So I was lucky that I had champions in the system, but the healthcare system itself was not interested in having a conversation with me, sadly.
Okay, thank you. And we have one last comment. Let me see. I remember with sadness watching a young woman miscarry in HSC-ER many years ago. I did nothing to help her, but I have often wondered about her. I wonder how those 40 people who didn't help in Regina think about your experience.
It's such a small world that I have known people who knew people in that waiting room. So someone actually came up to me and no one knew it was me. Everyone knew that this had happened at the hospital. Someone came up to me and just said, "Yeah, did you hear about this woman who just gave birth on the floor at Regina General Hospital?" And they were just meaning to talk to me about it. And I said, "Yeah, that was me." And they said, "Oh my goodness, my uncle was in the room that day. and he felt terrible and he was shocked. And then she actually shared that he felt traumatized by the whole situation. So I forgive those people because I think it was a little bit of the just frozen. I think everyone was frozen. And just that one lady who I swear must have been a mother and a grandmother who stopped by and was like, "Can I pick up your baby? And look at your baby who's so beautiful." So yeah, I don't know what they'd feel, but that was expressed to me as well, that they actually kind of have their own trauma from watching it unfold as well.
Awesome. Awesome. Thank you so much. Thank you so much. Okay, so I guess we'll end the Q&A now, but thank you so much. And I'm sure we'll be contacting you later. And that was just excellent. So thank you.
Thank you so much. Really appreciate the time and really appreciate the invite. I hope everybody enjoys the rest of the summit.
Thank you.
Thank you so much, Cassandra. What an impactful start to the 10th annual Patients Redefining the Future of Healthcare in Canada Summit. I was really moved by your story and really it's impressed by the changes you've been able to make within the hospital that caused you such harm, and the powerful example that you shared of All Nations Hospital. And thank you for your calls for visionary, bold leadership and proactive interjurisdictional collaboration. These are definitely potent calls for action, and they could definitely lead to meaningful transformation within the system. So that really the kind of care and the best practices that you had planned for yourself could become the norm for everybody. And thank you, Sharon, for your skilled moderation. So we're now heading into a 30-minute lunch break, so everyone can enjoy a bite to eat and some time to stretch or do whatever it is you need to do to be able to re-energize and recenter yourself. So please do come back in 30 minutes. That's 12:30 Eastern time zone. And we'll see you soon. See you in 30 minutes. Thanks, everyone. Welcome back, everybody. I hope you enjoyed a refreshing bite to eat and had a chance to move your body a little bit. Now it's time for our first panel of the day of the summit. Financial toxicity as a barrier to care is such a critical topic, and I'm thrilled that we are spending some time on it today with all of you. To help us explore it further, I am honored to introduce today's moderator for the Financial Toxicity panel, Kimberly Sega. Kim has over 20 years of dedicated nursing experience. Her journey in healthcare began with a passion for patient care and a commitment to making a difference in the lives of those affected by chronic conditions. As a psoriasis patient and mother to a child with severe eczema, Kim brings a unique perspective from both sides of the curtain. Over to you, Kim.
Thank you so much, Leah. It's my pleasure to be here, and I'm very happy to be able to moderate this panel this afternoon. So, financial toxicity, barriers to patient care. The financial impact of illness often creates significant barriers to accessing care, resulting in poorer health outcomes. The burden disproportionately affects vulnerable populations, including individuals with fixed or low incomes, those unable to work due to illness, and people living in rural or remote areas who must travel for treatment. The panel will present their experiences and discuss a groundbreaking report examining the economic challenges faced by people living with cancer and highlight programs designated to reduce these barriers. So now I will introduce our three speakers. We have Kathleen Barnard. Kathleen is a stage 4 melanoma survivor and the president and founder of the Savior Skin Foundation, where she now champions patient advocacy, education, and access to treatment. We will also have Rebecca Lonsdale. Rebecca is a registered nurse from Nunavut with 20 years of experience and of Inuit ancestry. She is a graduate and of the renowned Nunavut Arctic College and Dalhousie University Arctic Nursing Program. She currently serves as a nurse case manager at Iqaluit Health Services for the Qikiqtani General Hospital. And finally, we will have Stephen Piazza. Stephen is the Director of Advocacy for the Canadian Cancer Society, and in his role oversees issue-based campaigns, public engagement, and drug access. So without further ado, our first speaker, Kathy.
Good morning, good afternoon, everybody. I'm honored to be on this panel today. So I'm going to do it as a story tell. I have experienced financial toxicity. I have lived financial toxicity. And now I'm trying to help others facing financial toxicity. 50 years ago, my dad was diagnosed with esophagus cancer. We lived in Powell River, a remote area in British Columbia, with no cancer center, no cancer specialists. Even though we were 90 miles from Vancouver, where the BC Cancer Centre was, it would take over 5 hours or more to get there. There were 2 BC ferries in our travel. My mom and dad didn't know Vancouver. They were immigrants from Scotland and had never driven in that city. So it was up to myself or one of my siblings to get them to consults, surgery, radiation, treatment, etc. As most of us know, when we're dealing with Canada or with cancer, none of these run concurrently. So it wasn't like we could make one trip and everything would be done at the same time. It was numerous trips back and forth. Sometimes we get to the ferry and it would be canceled. Sometimes we would get all the way to Vancouver in the cancer center, only to be told the appointment had been changed or canceled. My dad obviously couldn't work. My mom had to take leave of absence from her job. My brothers had businesses and were self-employed, so any time away from work for them would financially hurt both of their young families. I had just finished university in Vancouver and was looking for employment and decided at that time that I would stop looking for work and help my parents. There were numerous times throughout that process that my dad just wanted to throw his hands up, throw in the towel. He could see how it was affecting the family emotionally and financially, but we were never going to let that happen. After a year into his diagnosis, we met with the doctor at our local community hospital to see if there was any way we could continue his treatment in our hometown. We had already discussed with his oncologist in Vancouver, and he had agreed if our physician in PR, Powell River, was open to the idea, we would move forward. So after a year of going back and forth to Vancouver every 21 days, we could settle at home, closer to family, friends, and our community support system. I can't imagine the financial toxicity my parents face because we were so thankful to have care for my dad and to have my dad. We never discussed it. Next slide, please. I was 48 years old when I experienced my own financial toxicity. I was diagnosed in 2003 in the prime of my life, enjoying my family and my career. And like many of us in our 40s, I assumed I would have years to save for emergencies and retirement. It became clear very early on in my battle with melanoma that I was not going to be able to continue to work. I was fortunately in that I worked for a company with benefits and was immediately placed on disability income. Although this helped with my month-to-month expenses, it did not allow for the unforeseen costs that cancer would incur. Both of my sons were in university at the time. So for anybody who has children, they know that's an expense into itself. The only treatment option at the time was available to me was called interferon. I remember my first visit with my oncologist. He said he had good news and bad news. The bad news was that I had stage 4 metastatic melanoma. The good news is I wouldn't have to pay the $15,000 for the treatment as it would be covered. I remember thinking, I live in Canada, why would I have to pay for a cancer treatment? The year of treatment took such a toll on my body that the oncologist said I needed a series of injections to boost my low blood cell count. I would possibly need 5 injections. Each one of them cost $2,500. I remember that day quite vividly. My mom and sister were with me. I was sent over the pharmacy, not connected to the hospital, but across the street, at which I got the first dose, my $2,500 in a little bag. I carefully walked it back to the community cancer center to have them inject it, to be told they couldn't because I had not gotten it and couldn't have gotten it from the hospital pharmacist. So I had to take that $2,500 little bag with me to a public health nurse or somebody that was going to be able to administer that for me. Being very Scottish, I was determined I was going to only need one of those $2,500 injections because the thought of having to pay for 5 of them kind of made me a little nauseous. I did not have critical illness insurance or really savings that could cover the cost of those injections. So it became necessary for me to start drawing from my retirement savings plan. So now the cancer was really taking a toll on my future retirement income. Unfortunately, the cancer continued to spread. I was given a palliative treatment at my local community cancer center. It was 15 minutes from my house. And I was told then that we'd know by the 3rd treatment if it was working or not. It was not. My son contacted an oncologist in the US and said, please save my mom, and was told about a clinical trial that they were using in the US. I could not have that treatment in BC as I would need to be in hospital for the duration of all treatments with round-the-clock nursing care. We would soon learn that there would be a cost, and for me, the cost was $40,000. My husband and I both had private insurance plans, and neither of them would pick up the cost. When I found out how much that drug would cost, even though it was my only hope, I told the family I was not going to take it. I couldn't bear the financial burden that this would put on my family. But they convinced me, and off I headed to Edmonton, Alberta, to the Cross Cancer Center. Each visit lasting for a week over an 8-week period. A family member would have to come with me to support me on these treatments. So in addition to the cost of the drug, we were now dealing with the cost of airfare, hotels, meals, and all incidentals that accompany being away from home. My family accompanied me to Edmonton every trip. And I know because all of them were self-employed and they were not being paid, their costs alone ran at least $10,000 in total. Unfortunately, it still wasn't over for me. It came back again, and the only option was to either re-challenge the previous treatment or to find another trial. Firstly, I knew my body could not take that previous drug, as near the end of the final week of treatment, my body started to shut down. And secondly, I was not going to put out another $40,000 for a treatment that I knew already didn't work. We were told then there was a new innovative treatment, and I could receive on compassionate access. So off I flew to Edmonton again. This time, I refused to take a family member, as now the financial toxicity was getting way more than I could bear. So I would fly alone every 21 days for 4 doses. Fly in the morning, home in the afternoon, all alone, tired, sick, and mentally exhausted. But here I am today, 22 years since diagnosis, when I was given 3 to 6 months in 2003. Next slide, please. So I had my coworker kind of flip this slide around my journey into what the financial toxicity really looks like. At a minimum, from 2003 to 2007, my cancer cost our family $69,000. And again, as I mentioned, as we had to start pulling from our retirement saving plan, there's tax implications to that. We were told to hang on to all our receipts because, you can use them when you file your income tax. And really most of the costs ended up being my sister's. And when she tried to put them through her income tax, was told that she wasn't allowed to do that. Only the patient or the caregiver or loved one could. So she never ever did get any of that money refunded to her. When I got the first drug, the interferon, I had 5 weeks of high dose, which was at my community center. So again, it was 15 minutes away. So really the only cost to us was the parking. But it wasn't exactly what I thought, because around every cancer center, it's not cheap to park. The parking is usually full. And on my fourth treatment there, I parked on the road and I knew it was a 90-minute infusion. So I put in enough for a 3-hour parking. I went in to get my treatment. And it was one of those days for anybody who's had cancer where they couldn't find the vein. And they tried and they tried and they tried. Finally, we found the vein. But unfortunately, I forgot that we had now run over the 3 hours that I put into the parking meter when my treatment was complete. As if it wasn't sad and hard enough, I went only out to a $275 parking ticket, at which I phoned the parking meter attendant and begged him, on what little life I thought I had left, to please reverse that with an absolute no. The second drug with the dicarbazan was just a parking because I was able to get it at my community center. But still, again, for a lot of people, those parking costs add up, add up, add up. The hardest for me was the interferon drug that I got in Edmonton, Alberta. The flights, the accommodation, cabs, incidentals, meals, my family having to come with me. It ended up in excess, and the cost of the drug. It ended up in excess of $65,000. The last treatment I got, because I decided not to take family, was a little bit cheaper, but I still had flights, accommodations, cabs, incidentals, meals. It was not an easy journey financially for my family. In our cancer-free retirement years, my husband and I ended up selling our home as the costs of all of those treatments had gotten way too big for us. But how lucky for us that we had the financial means to come out on the other side. I talk to patients every day that don't have those means, and it's heartbreaking to me. Next slide, please. Financial toxicity isn't a statistic. It's a relentless, real-life battle. Cancer is a monster with a very dark heart. It can bring fear, anxiety, and often depression. It tries to shatter your confidence and can shatter your faith. Physically, it brings pain, and quickly, if you let it, it can strip you of your vanity and your pride. And sadly, it tries to take away all the dreams you had for the future. Retirement, travel, kids, grandkids. You start seeing your life in terms of months rather than years. Oddly, with everything that I was going through emotionally and physically, what took the wind out of my sails was the financial burden this disease would bring to my family. Next slide, please. So, how did we as a family want to help? We started the foundation in 2006 to really help those patients that were in the place that we had been for way too many years. We help patients deal with non-melanoma skin cancer, melanoma, and ocular melanoma. All funds received through donations to Save Your Skin go directly back to patients needing financial assistance. Patients are given our 1-800 number, hopefully, at diagnosis, which I pick up 24/7. And we tell patients, no ask is too small, no ask is too big. We will help you. We have paid for parking, daycare, travel within Canada, accommodations, Ubers, cabs, food, incidentals, side effect medication if needed, travel outside of Canada, and even sometimes we've helped with treatment. We have helped with special equipment like walkers, wheelchairs, even medical air transportation to get patients back to their families and support systems when they couldn't fly commercial. We have financially assisted over 500 patients to a tune of $600,000. Now that we're starting to see more nurse navigators across this country, we are working closely with them when patients are diagnosed to ensure that we are working together so that all patients' needs are met when they have to travel within or outside their community. These numbers didn't even include the work we did during the COVID, when the world stopped, but cancer did not. Patients needed to get to appointments, surgeries, treatments, and a number of patient advocacy groups joined together to help patients in need. We developed a website hub to ensure that patients were getting all the updated information they needed. Because as many of you remember, information was changing daily, sometimes hourly, and we wanted to make sure patients got what they needed. We partnered with taxi companies in Toronto and Montreal to ensure the seamless transportation for those who needed it. We even had patients that needed to get from British Columbia or Alberta or Saskatchewan or Manitoba to clinical trials in Toronto, and we were doing everything we could behind the scenes, whether it was train, plane, or automobile, to get those patients to the life-saving treatment they needed. We even built a virtual care resources for patients because we knew now most patients weren't going to be going to see their doctors or their specialists. They were going to be doing it through a virtual platform. And a lot of patients didn't even understand virtual platforms. Next slide, please. This past year, we have been contacted by patients with other cancers, rare carcinomas, rare brain cancers, all needing support both financially and emotionally. They're not able to get treatments through to our healthcare system or financial restrictions. Their only chance of hope and or survivorship is to leave their province, sometimes their country, being thrown into financial distress or just giving up. Period. Full stop. We must do better. Next slide, please. Thank you for your time and attention. And please, let's keep working together to make a difference for Canadian patients. Thank you.
Thank you so much, Kathy. And we'll move on to our next speaker, which will be Stephen.
Thank you so much. And Kathy, thank you so much for that presentation. It really is a true privilege to follow you and all of the work you've done in this space. And I really appreciated how you grounded this conversation in your experience and the patient experience. So good afternoon, everyone, and thank you for being here for this important conversation. As Kathy explained, today we're talking about something that touches every part of the cancer experience, not just treatment and recovery, but the financial realities that come with it, the cost of cancer care in Canada. Cancer remains one of the leading causes of illness and death in this country. Its impact on our health system is profound, and its impact on people in terms of physical, emotional, and financial tolls often feels immeasurable. And that immeasurability, that sentiment was expressed by one of our patient partners in our work, who said that the physical and financial toll of cancer feels beyond measure, but patients, survivors, and caregivers know all too well that the financial burden is real, and so we must measure it. Because what cancer costs us as an individual and as a society matters. If we go to the next slide. So through this presentation, I'm going to cover 3 pieces of work done by CCS on this issue over the past year. So our stats report on the economic impact of cancer in Canada, work we did with the Angus Reid Institute on how Canadians perceive these costs, and an evaluation of our programs and services in BC that underscore the link between financial toxicity and treatment outcomes. Next slide, please. So for a report at the Canadian Cancer Society, through a collaboration with the Canadian Cancer Statistics Advisory Committee, Statistics Canada, and the Public Health Agency of Canada, we published the Canadian Cancer Statistics Report. Every second year, we release a special report on a topic of particular relevance to the cancer control community and Canadians at large. Last year, that topic was the economic impact of cancer. Our report provides the most updated and detailed estimates of the cost of cancer in Canada, focusing not only on cost to the health system, but also cost to people with cancer and their caregivers. And for the purpose of this report, the cost to people with cancer and their caregivers include direct out-of-pocket costs, as well as time costs related to time spent receiving care, representing time away from doing things that are important to the individual. And finally, costs related to lost earnings due to changes in employment. These costs for both the health system and people affected by cancer are reported by cancer type and across different phases of care. The report also looks to the future, providing a view on what we can expect for the economic impact of cancer over the coming decade. So on the methodology, all of these projected estimates were generated using a microsimulation tool called OncoSim, which is a powerful tool that uses rich Canadian data sources to enable important analysis like what I'm presenting today, really enabling decision makers, patients, and patient organizations to better understand cancer control and where they can make a difference. This report would not have been possible without this powerful and unique tool, which is led and supported by the Canadian Partnership Against Cancer, with model development by Statistics Canada and funding from Health Canada. Next slide, please. So, as I mentioned, the impact of cancer and the costs were profound, and we're going to continue to talk about that in this panel today. Through this report, though, we heard from our patient partner, Vanessa, an advanced colorectal cancer patient who had to deal with the stress of perhaps not being able to pay rent. And that's because in 2023, she paid over $4,000 for prescription drugs alone as part of her treatment. Next slide, please. So now let's get into the bulk of this report. In 2024, we estimate that the total cost of cancer to society was projected to be $37.7 billion, with about 80% of this cost borne by our health system and 20% borne by individuals with cancer and their caregivers. Costs to the health system as a result of this are projected to be 30.2 billion. So 30.2 billion of that 37.7 billion are covered by our health system. While we project the costs to people with cancer and their caregivers collectively amounted to $7.5 billion last year alone. So throughout this report, these costs are broken down by phases of cancer care. And just to give you a sense of how I'm going to be talking about this, the initial care phase for the purpose of this report covers the period from diagnosis to the first 12 months of care. The continuing care phase covers from 12 months to 10 years. And finally, the last phase covers the last 12 months of life. So the key takeaway in all of this is that cancer care requires significant investment, not just from our public health system, but from private individuals as well. Recognizing and addressing these considerable costs is crucial to improving support for those living with and beyond cancer and planning for sustainable healthcare policies. Next slide, please. So I'm going to spend a lot of time in this presentation covering the out-of-pocket costs that you see here on this slide. But I first wanted to go into a bit more detail about our costs to the healthcare system. So this is a really complex issue to be able to address these impacts for people with cancer and caregivers, as health systems are also facing financial constraints. While ideally, we'd want to make care more available in areas of lower population density to meet the needs of populations that are underserved and disproportionately affected, the reality is many cancer services today require centralized facilities with sufficient staffing. And from a health system perspective, this requires a significant investment in health human resources. Not surprisingly, many specialist services depend on sophisticated high-cost technologies that are only available at centralized centers. And the cost of care goes beyond that first year after diagnosis, with considerable health system costs in the following years. So from a health system perspective, where we see the majority of the costs are in the continuing care phase. So that's the 12 months to 10 years after diagnosis. The costs during this phase to the health system are $12.6 billion. Understanding these phases of care is critical to healthcare planning. The initial and ongoing care of individuals who are living with cancer requires sustained health resources, whether through regular checkups or surveillance, continuing treatment, or palliative care throughout. The aim is for this data to guide policymakers in allocating resources to meet the needs of people with cancer at every stage of the cancer experience. If we go to the next slide, please. So aside from the cost to the health system, what this report really highlighted is that cancer comes with an incredibly high price tag for individuals, and it's unacceptable to know that such a significant portion of costs fall on people with cancer and their families. This report looked at just how high these costs are. The average lifetime cost to people living with cancer and caregivers are projected to be nearly $33,000 over the course of your lifetime. Now, we broke this down and over half, so about $16,000 are direct out-of-pocket costs. So those are things you'd be paying cash or credit for. About 11,000 is related to lost time, and nearly 6,000 is related to lost income due to changing employment status. The out-of-pocket costs include things like prescription drugs, home care, travel, and assisted devices, many of the things Kathy talked about in her presentation. For an individual, the majority of these costs come in their first year after diagnosis. So whereas in a health system, we see the majority of the costs coming from 12 months to 10 years, for individuals, the majority of your costs are going to come in your first 12 months. And this is just the expected average lifetime of the cost of cancer for Canadians affected by the disease. This average is really going to vary depending on where you live, the financial supports available, and whether you need to take more time off work for necessary treatment and care. And we know that this burden isn't felt equally. With those in low-income households and those on fixed incomes disproportionately affected, as well those in rural and remote communities far from treatment, paying more for travel costs and receiving care. So that 33,000 is an average, but that's going to vary for all of the reasons stated, and we're hoping to discuss more of that today. If we go to the next slide, please. So once we launched this report last year, we socialized it through public campaigns. And then we partnered with the Angus Reid Institute to understand how Canadians perceive these costs. So we pulled 2,000 Canadian adults from January 10th to 17th with the support of Angus Reid through the Angus Reid Forum. And if we go to the next slide, the results were really striking. Among working age Canadians, 80% said they would struggle to save for retirement if faced with the cost of a cancer diagnosis. So we presented the costs outlined in the report to the individual, and then we asked a series of questions about how they would respond or how they would pay for those costs. 2/3 of Canadians expected they would need significant unpaid time off work, and 42% worried they'd miss out on opportunities for career advancement. Among those who have experienced cancer firsthand, 40% reported struggling to save. 1 in 5 said it was difficult to pay for monthly household expenses, and nearly 1 in 4 said it was hard to make payments on non-mortgage debt. So through all of this, we saw that the first thing people would pull from is their retirement and their savings. And essentially, with these costs of cancer, we're asking working age Canadians on average to sort of rob from their future planning to pay for their present costs of dealing with the disease. So that was really a striking finding. If we go to the next slide. So again, these are some of the key messages I spoke to, but we often talk about direct out-of-pocket costs. We don't often talk about hidden costs. And one of the hidden costs that I found really striking in doing this work is the 42% that felt it would be likely they would be demoted or miss an opportunity for advancement because of taking time off and the cost of cancer care. And that missed opportunity compounds throughout the trajectory of your career. So it's not just lost income this year, it's lost income for every year throughout the remaining years of your career. Certainly something we hope to talk about more when we're talking about cost of cancer. Next slide, please. Finally, we ask Canadians who should bear the main responsibility for costs that aren't currently covered. Not surprisingly, the majority said either the provincial or federal government. So not taking any excuse for the individuals to pay out of pocket, the majority of Canadians said that either the federal government or provincial government should be picking up these costs. This was followed by 1 in 5 who said private insurance should do more. Fewer than 1 in 10 believed it should fall on the individuals themselves. And this really reflects a shared belief that no one should be financially burdened simply because they were diagnosed with cancer. Next slide. So thus far, I presented on the economic impact of cancer in Canada and the perception of these costs among the Canadian public. Now I'm going to ground this work in an evaluation of our support programs to demonstrate the value of removing financial toxicity when it comes to accessing care. Next slide, please. So to begin this section, in October 2023, CCS expanded its cancer travel and accommodation services programs in BC, and you can see our programs there. I'm going to use the acronym CTAS So that speaks to all of the programs you see in front of you. So our travel and our travel treatment program, our lodge and hotel accommodation, our Wheels of Hope volunteer driver program, and our partnership with Hope Air. The CTAS BC program aims to alleviate part of the financial burden on clients who need to travel to receive cancer care and who would face financial hardship to make such trips. So CCS is using funds to expand access to travel and accommodation services for people with cancer who need to travel outside of their home community for treatment and are facing financial hardship as a result. The program enhancement started in 2023 and included an increase in access to our travel grants, expanded ground transportation through Wheels of Hope, coverage for cancer lodge accommodations, and a partnership with Hope Air for air transportation support. And you can read about any of these programs and the full CTAS suite of services at cancer.ca for more information. So next slide, please. So in 2024-2025, the first 18 months of these enhancements, we evaluated the program and used a mixed method approach to understand how the program was implemented and its impact during the first few months. So we combined formative, substantive, and developmental evaluation strategies, formative to improve processes during delivery, semantive to assess overall effectiveness, and developmental to guide adoptions in a rapidly evolving context. Data collected for this evaluation included a document review of planning and management materials, a client and caregiver survey that ran from January to February 2025 with nearly 1,000 respondents, providing qualitative and quantitative insights into the user experience, administrative data analysis, and semi-structured interviews with program staff, volunteers, and healthcare providers, along with a focus group of clients, caregivers, and volunteers. And the survey design here incorporated validated measures to assess treatment compliance, financial toxicity, emotional distress, and empowerment. Geographic reach was analyzed using postal codes to identify rural and remote access. Data cleaning ensured accuracy, and demographic segmentation highlighted underserved communities. And this report really provided a comprehensive, evidence-based understanding of program performance and areas for improvement. And some key findings from this report really showed that every program had a positive impact on all domains measured, including compliance with treatment and financial toxicity, reducing costs of out-of-pocket, and emotional distress and empowerment. If we go to the next slide. So, for instance, on compliance with treatment, clients were asked, to what extent has your ability to continue to complete your cancer treatment changed since accessing these programs? 71% of respondents indicated that accessing the programs improved their ability to continue or complete their treatment. 77% of respondents indicated that the program increased their motivation to continue on and complete their cancer treatment. So really profound and showing that direct link between alleviating that financial toxicity and adherence to treatment. Next slide, please. So when it comes to reducing financial toxicity in and of itself, 77% indicated that the programs made them less financially stressed. 56% of clients and caregivers reported that because of the programs, they worry less about their future financial problems related to cancer care and treatment, related to their cancer treatment. And that really ties directly back to the perceptions that we saw from the Angus Reid report, where people were worried about their financial future because of the immediate out-of-pocket costs they had to face when facing a cancer diagnosis. And 27% were more able to meet their monthly expenses. Next slide, please. So again, continuing with the financial toxicity and the reduction of direct out-of-pocket costs, 85% of respondents indicated that the programs they accessed saved them money. And on average, respondents reported that they saved more than $4,000 as a result of this suite of programs. Next slide. So I've presented on three sort of key foundational pieces that CCS has done to measure the cost of cancer in this space, be it the economic impact on people facing cancer and society, perceptions of that impact, and then how programs and services, not just for CCS programs and services, but programs and services delivered by cancer charities and patient organizations help to address those gaps and reduce the cost of cancer and support adherence to treatment. Over the past year, since doing all of this work, we launched a pan-Canadian campaign highlighting the out-of-pocket costs faced by patients and caregivers. And we invited people to join us in calling for change. I'm really excited to report that to date, over 100,000 people have joined our campaign to take action and call on provincial and federal governments to fill some of the gaps in the cost of cancer care in Canada. And you can learn more about this campaign or get involved at cancer.ca/cost of cancer. Thank you so much for your time, and I'll hand things back to the moderator.
Thank you so much, Stephen, and thank you so much, Kathy, for your very insightful presentations. And unfortunately, our third presenter, Rebecca, due to unforeseen circumstances, will not be able to join us today. So we will head straight into our Q&A. So I'll start things off with our first question. So sometimes we only think about the direct cost on patients and families. Could the panelists reflect on the longer-term costs related to reduced earning potential and savings if people aren't able to work during illness? And do you have any thoughts on the adequacy of critical incident insurance or disability insurance and how this could be improved, or what else may we need?
Stephen, do you want me to start?
Yeah, sure.
Okay. I'm lucky because I have two financial planners within my family. So I realized very quickly that critical illness is probably something my husband and I might have wanted to look at. But again, when we were first married, everybody was, thinking you needed health insurance or life insurance. Sorry, not health insurance, life insurance. Because, we wanted to make sure our kids would be looked after and taken care of in, the event of our death. Never thinking, honestly, that a cancer diagnosis or any diagnosis, critical diagnosis in Canada was going to cost us our home. I do want to say, though, that, there's other opportunities that I think we need to start looking at. We need to really start talking about treatment closer to home, regardless of where we live. And that's what we do at Save Your Skin Foundation behind the scenes. Most of you know the innovative medicines that came into cancer did come into melanoma first. And we were only able to access them in our larger urban centers. And that just wasn't acceptable to me because the patients that were contacting us were from remote areas and rural areas, and they didn't want to have to travel to the city for treatment. So we started working with our physicians, our healthcare providers, to start figuring out how we were going to move those treatments closer to home for our patients. And we've had some really good successes. We have doctors from the Cross Cancer in Edmonton that the patients don't come to them. They go to Yellowknife to the patients. There's a lot of opportunity for us to be able to move our patients closer to home. We, when we first got access for our ocular melanoma patients, it was all clinical trial and access out of Toronto. We were moving patients back and forth to Ontario from every other province. I mean, we just couldn't sustain that. And the patients can't sustain that. Right? I mean, we have all these wonderful pockets of money for the patient, but I can tell you, they're not always carried over to the caregiver. So the patient may get a lodge for free or sometimes even just a discounted rate, but there's a lot of times where the caregiver still has to pay those monies. So to us, we can't just have one or four centers of excellence across this country. We need to be having community cancer centers and even sometimes community hospitals that are going to, and private infusion centers that are going to be able to help us in this space. Stephen, I'm sorry, I'm not really answering the questions, but I had so many comments after your presentation. I just have to say a few things. I loved when you asked the question, who should help? Because I asked my husband that last night when I was talking about the $600,000 that we are so proud that we've been able to give to patients. Who is that? Who should that be? You talk about private payers. We very seldom get access to private payers or anything from our private payers. We have sorry, 1 second. We right now have 2 patients that needed to get home from a clinical trial in Toronto back to British Columbia and couldn't take commercial flights because they were sick and they just could not move. We ended up having to get them medical access by a private jet to get them home. They couldn't fly commercial. And when we worked with their private payer, they were going to give a maximum of $2,000. It's $65,000 for those patients to get home. So who does help here? I mean, I've talked to patients that have sold their homes, lost their homes, that have their line of credit so high they just can't afford it, and that are even doing GoFundMe pages. How do we get to a system where that's the case?
Absolutely, and there's a lot of comments, Kathy, and I appreciate them, and I'll take them along with the original question that was asked. So just to get back to the original question that was asked, to quickly address that from my perspective, I think it was around outside of direct out-of-pocket costs, what other costs and what work is being done to look at those costs. I will say in the $33,000 average figure we have, 16,000 are direct out-of-pocket costs, but the remainder include lost time and lost income. And when we look at lost income in particular, there's a few things I wanted to highlight. So a few years ago, CCS, along with a number of patient organizations, advocated for an extension to the EI sickness benefit. So it was at 15 weeks. We advocated with our partners in the charity space to extend it to at least 26 weeks. And that at least better aligns with the treatment and recovery phase for some of the more common types of cancer. So we extended it that way. But that was federal legislation. What that didn't do is provide job protection at the provincial level for provincially regulated workplaces, which is the majority of workplaces in Canada. So we were at a time in a system where you could take 26 weeks off and get an employment insurance income support for that, but you actually had no proactive job protection in the province you were working. So your job may not be there when you go to return to work. And there would exist some recourse. You could make a labor relations board complaint or human rights complaint, but we wanted this to be proactive, stated in legislation that if you took this time off, your job would be there for you waiting when you were ready to return to work. So I'm happy to say that since that EI sickness benefit was changed, we now have 7 or 8, depending on how you're measuring it, provinces that have signed on and actually mandated at least 26 weeks of job protected leave, because that return to work phase is so important when we're talking about post-treatment and making things easier. Kathy, to your point, I think it's really interesting. I think we all agree on this call and in the audience on the problem. And the problem is patients are paying too much out of pocket in our universal healthcare system to access cancer treatment. And then it becomes a question of whose problem is this to solve? And I find as patient organizations, we do go to the government a lot because, again, in a publicly funded system, and people facing cancer and the Canadian public has backed us on this, as we saw through our polling insights, it is the majority. We believe it's the majority of the government's problem to solve, to eliminate the gaps for these payments. But that takes time, energy, effort, and years. So I think a really exciting conversation is what can patient organizations do with industry, with partners, to at least fill the gap, and help as many patients as we can today while we advocate for changes that will help all patients tomorrow. And I think having those conversations about how we could work more creatively with insurance, how we could work more creatively with banks. For instance, some mortgages would have, built in, I understand from financial planners, a pause to mortgage payments if you're diagnosed with a disease like cancer for a set period of time. Again, it's not going to help you throughout the duration of your treatment, but it's something in that first 12 months to help you settle and sort of take stock of what you can do. So even looking at things like that and making sure things like that are offered in every mortgage plan, I think could be an interesting place to start. But I really do like the question and would encourage a conversation around what can we do outside of government in the immediate sense to fill some of these costs.
Thank you so much for that, Stephen and Kathy. We have another question here. Are cancer patients accessing disability tax credits? And if so, just to understand how relevant it is for cancer patients.
Do you want to start, Kathy, with, I could go into tax credits, but not specifically disability tax credit.
Yeah, I don't know much about the disability tax credit either. And maybe that just speaks to the problem, right? I think when I was diagnosed and in turmoil, my family and I were in turmoil, it was trying to find and get access to all those, Hope Air and all the hubs, because there is help out there. It's just finding it. And when families are in that space where we've been diagnosed, we're already having appointments, terminology that we don't understand. We need a central hub system that really helps people. And I think, Stephen, that's, maybe advocacy groups, we start talking a little bit and having financial planners and bankers doing webinars with us. Maybe these are ways that we need to educate Canadians that there is help out there. And we shouldn't be always expecting that the federal and the provincial governments are there or the private payers in these instances. But I don't know much about the disability tax credit. I don't know if you would know anything about it, Stephen.
Well, I think the broader problem that we're touching on is the navigation of all of the supports that may or may not be available to you. We deal a lot in advocacy with the sickness benefit. We're calling for the caregiver tax credit, which is a federal tax credit right now, to be made refundable, because right now, as a non-refundable tax credit, it only counts against any taxes you have owing. So you're not actually refunded any dollars because of that. And that means it's disproportionately less impactful to people living on lower incomes. But I think when we speak to people living with the disease, it is really, underscoring the importance of navigation. And we do that in various ways, like I'll invite people to visit cancer.ca and our cancer information helpline, which could help with that. We have a community service locator that helps show services that may be available in your community. I think at a hospital level, you have patient navigators, you have drug access navigators, you have sort of infrastructure to navigate specific problems. But I think all of those potential solutions come together at the patient level. And it is a conversation about, who is drawing in all of these different things that a patient may have access to, and supporting a patient from point of diagnosis through to any point in their treatment on those sorts of things. So I think the navigation challenges, because the solutions to cancer are not one, but 1,000 solutions across tax credits, across federal, provincial jurisdictions, across cancer organizations, are so complex that navigation challenge is really something to highlight as we talk about solutions.
And I will say too, Stephen, and that's changed even since I was diagnosed, because I have to tell you, we work closely with the navigation nurses across the province. And I can give you a few examples. We have a couple of ocular melanoma patients in remote areas in Manitoba. And they need to get into Alberta to see the specialist there. And we work closely with that nurse navigator. She knows where little pots of money are. She's kind of our hub. And we know for those two patients that Save Your Skin or Ocumela Canada that we also run are kind of the last bucket that we need to go to. So what she'll do is she'll go out and she'll do all her little research. There's small charities or small companies in the province that will donate, some gift cards, maybe some Uber cards, and she'll start collecting that. And when she's collected everything she can, within her province, then she'll reach back out to us and she'll say, Kathy, we still need some accommodation. We need some travel. Can you start looking to navigate that? And then that's where we pick up. So we'll start getting onto your website. We find, we reach out to the Hope Air, et cetera, et cetera. We find accommodations that you might have used with Canadian Cancer Society in the past, and we kind of bring all of that holistically together. The patient doesn't even know that's going on behind the scenes. It's navigated by the nurse navigator, and it's an easy clean for them, right? They're picked up by an Uber. We've got an Uber account. They're dropped at their hotel. The Uber takes them to treatment, et cetera. So again, those nurse navigators within those centers have really, really, really picked up the ball since 10, 15 years ago, when we didn't have the luxury of those nurse navigators. So I can't speak highly enough of the work that they do behind the scenes for these patients as well, right?
I completely agree. And it's that connection between patient organizations and the nurse navigators, the people doing the navigation, that really brings it all together. As you say, like for social workers or nurse navigators, like having organizations like Save Your Skin, like CCS to refer to, and making sure they're aware of our services to refer to them for people that need them, I think is really important. So almost embedding patient organizations in the sort of health system in that way.
Exactly.
Thank you so much. And I do think it brings up a bigger question of who's telling these patients about what is available for them. And to piggyback off of that, and I do think you answered it a little bit, but what can different stakeholders do to help and make this whole process easier?
Well, I always say collaborating and working together. And I have to say, we're pretty good at that in the patient advocacy cancer space. I'm proud of the work we do. When the innovative medicines first came to melanoma back in 2011, the first thing I did was reach out to all cancer patient organizations and say, this is coming our way. It's a different medicine. It's innovative. It's extremely expensive, and we need to really work together to get this to our patients in a timely manner. So I have to say, I think the collaborations and the communications we have amongst ourselves as patient advocacy groups and the Canadian Cancer Society are imperative. I really do, because we can't be everything to everybody. I am a small charity, in the scheme of things, but I don't want patients falling off. And I worry about the patients that don't find a me. Right? Because the financial toxicity is something that we can help them with. That's why we raise money. That's where all our funds go. So, what about the, uninformed patient that can't find an advocacy group like myself? Where are they going, and are they able to get what they need? And I worry about that demographic.
Absolutely. And commenting on the cancer charity space, it is highly collaborative because there's no shortage of problems that need to be solved. So there's certainly no territorialism over who has jurisdiction, because there's just so much to do in this space. And I think in an immediate sense, it is continuing our collaboration around our programs and services to see, what suite of services are available to this particular patient and where can we pull from, whether that's CCS programs and services or Save Your Skin or so many others. How we could navigate all of these to make sure that the patient is getting the support they need through treatment. But I think a huge piece of collaboration, and a very effective piece of collaboration, is in the advocacy work that we collectively do to solve a lot of these problems. Looking at things like, Kathy, you were talking about treatment closer to home. We're seeing cancer treatment, it's not a direct substitute, but move outside of hospitals with precision and oral therapies that can be taken at home. But we have gaps in provinces that still require patients to exhaust their private insurance and then pay any copay or deductible, or go through Trillium and pay that 4% of their household income. And I'm speaking of Ontario particularly here. But there's been a long-standing collaboration between CCS, between the Cancer Certainty Coalition, Save Your Skin, Rethink Breast Cancer, so many other organizations, to fill this gap in oral medications, which would go a long way to reducing both the direct out-of-pocket costs, but also, and importantly, the cost of time it takes to navigate this very complex system to get essentially coverage for what is a cancer treatment in the same way that an IV medication in hospital is a cancer treatment. So I think the advocacy space is really powerful and a really powerful space of collaboration among patient organizations.
Thank you. So we have another question here. Are there resources to locate interested stakeholders interested in funding initiatives?
So if that's someone in the audience who wants to fund an initiative they've seen from me today, please contact me directly. I'm happy to continue that conversation. I think any initiative presented by a patient organization is always open to more funding, because I hazard to guess that we're all operating at capacity in so many ways, and it is, we will fund as many for all patient organizations, we will fund or deliver programs for as many people as we can based on the funding we have. So whether there's a clearinghouse for all of these initiatives, I don't know, but I think if you have an area of interest, look up the patient organization that is doing something about it, and contact them directly, and get a sense of what you can do to support them financially, which there is a great need around.
And I will say to Stephen, this report helps an organization like ours, because we do reach out to ministers of health, hopefully on a regular basis or whenever we get an opportunity. I know it's always easy for me to go in and tell them patient stories. Our patient that was getting a clinical trial in Ontario, and it wasn't working, and her husband wanted to get her home for her son's 7th birthday before she passed away. And in 24 hours, we managed to help that family raise $65,000 so she could get home and see her son turn 7. So I think there's this report, like those stories are one piece, but I think we always know in advocacy, everything has to be backed up by data, and more data. And I think that's, from my perspective, for Save Your Skin and the work that we do, that's where the report will really help us, is that now it's beyond our one cancer, it's all cancers, and it's, countrywide. So I have to tell you, that's why I was thrilled when you agreed to come on the summit, because I think for most of us in advocacy, this is really a good document for us to use in our advocacy work when we're, working with our decision makers across the country.
I mean, thank you so much for saying that. That's fantastic to hear, and really, I think a lot of the vision behind a report like this, but it also speaks to the collaboration in this space, right? Like, I think CCS is set up to do a large national report across all cancer types, and release it, but then it really is, I think important for individual cancer organizations to talk about the specifics as it relates to your population or the community that you serve, and bring in those stories and sort of ground the average cost, Kathy, that I was speaking to is far below what you experienced for the cost in your journey. And I think, looking at decision makers, it's really important that we highlight, when highlight patients where so many things go wrong in sort of their journey and their treatment, because that's who we want a system. That's what we want to build a system around. It's to make sure that no one falls through the cracks. And I think that really is a huge value that I really get in working so closely with so many patient organizations in this space.
Thank you. So we'll move on. We have quite a few questions, so I'm going to try to get to all of them before we run out of time. So our next question is, how can patient organizations ensure that they are on the radar of navigators so that they can refer patients to us?
Well, I always, when patients contact us, the first thing I ask them, of course, is to tell me their treating physician is, and at which cancer center they're at. And then if I don't already have a list of the nurse navigators in that center, then I will email, because we work with the melanoma task force and ocular melanoma task force of physicians across the country. So I'll reach back out to them and have them direct us to that nurse navigator. I will tell you, as a patient, the most important person in my journey was the nurse navigator. And we will all tell you that if you ask us. Most of us, even 20 years out, are still in touch with our nurse navigators or the nurses that gave us our treatment within that cancer center. We know that they are the link between physician and any resources that we're going to need. So we do it really through reaching out to our medical community. And every year we do that in January. We reach back out to see what new treaters are in the space, right? We attend conferences to find out who's new and treating in the space. Nurse navigators are starting to come to the melanoma and ocular melanoma symposiums and conferences. So we're just trying to build that database as best we can, because the nurses move through the system quickly too. We might have them for a year and then they're promoted to, another role. So we're constantly making sure that we're keeping those resources current.
Yeah, those are great points. I really think it is that information sharing. I think a venue like this is a great example of how we could sort of bring nurse navigators and other allied professionals to the table to talk about like both the space and what supports are available, but also hear directly from them on what challenges they're facing and what new challenges they might be facing. So I think the information flows both ways. Like, we develop support programs and services to respond to challenges that patients face, but if they're hearing about a number of new challenges that patients are facing, resulting in whether it's a change to private insurer or some piece of legislation, or just new costs as we see more innovative medicines, technologies, assisted devices come into this space, I think that's really important for us to hear about as well, so that we could build and design programs and advocacy work to like continue to respond to patient needs. So I do think we have to make sure that information is flowing both ways when it comes to patient organizations and professionals.
Thank you. So our next question goes to the burden of deductibles varies across provinces and within publicly funded drug plan benefits. What is the ideal approach for advocacy to lower the access hurdle for all Canadian patients?
I could start on this one. That's a great question. There's sort of low-hanging fruit on this that I want to speak to. And that does come with provinces that don't provide universal access to oral therapies and make you go through your private insurance or catastrophic provincial insurance with a deductible in order to access those therapies. Because we're not even talking at this point about supportive medications. We're talking about actual cancer treatment that just happens to take place outside of hospital. So and I walked through this before, but I'll do it again. In Ontario, you first have to exhaust any private insurance you have. We know that about 2/3 of working Canadians have some form of private insurance, but it's not a question of insured or uninsured. It's a question of the level of insurance you have, because even among privately insured individuals, so many face co-pays or annual maximums. And when we're talking about a regimen of take-home cancer drugs, it's very expensive, $6,000-$7,000 a month. You're going to hit that annual maximum very, very quickly. And then it's a matter of looking at catastrophic programs. So in Ontario, it's something like Trillium, where you're paying 4% of your household income. And that doesn't include anything that's already paid by private insurance. So that 4% is what you are paying out of pocket to access your cancer treatment. And I think universal access to take-home cancer drugs, no matter where you live, because right now, if you're in BC, Manitoba, provinces like that, your treatment isn't looked at any different if it's in hospital or in oral therapy. You can take it home. It's only when you get to Ontario and then in some Eastern Canada provinces where these gaps start to appear, we start to ask pharmaceutical companies to fill the gap through a compassionate use program. things like that. Like I think insofar as low-hanging fruit and talking about removing deductibles, it's universal access to your cancer treatment in and of itself. So let's just start there. And I think if we even get there, we've made very good progress in this space compared to where we have been for the last 10, 15 years.
Yeah, and I need to speak a little to private insurance because even it's changed over the last years, right? We've got a patient with a rare brain cancer. They have a private payer. Their treatment right now that they're paying out of pocket is $13,655 a month. Their private payer has offered to pick up $2,000 a year for that. So, I mean, we need to realize that innovative medicines and technologies are not cheap. And to be honest, I wouldn't even know the actual ticketed price of the treatments that I get or other patients get. I don't want to. But what I do know is we as consumers and employers need to start really looking at the private plans and accessibility for treatments for patients in this new era of innovation. Because honestly, $13,000 to $25,000 a month is normal. We were the first cancer to get oral medications, our targeted treatment in 2011. And the fact that our patients in Ontario still don't get that as part of the public plan is shocking to me when we get it everywhere else in the country. It's really hard when we pull our patients together at round tables or chat support, and you must find this too, Stephen, because they don't understand why they live in one country called Canada and we're all getting different health care, across the board. Like, I think we just sent a letter saying thank you for taking tariffs off wine going from BC to Alberta, but could we take off the hurdles for our cancer patients in this country needing to move to get life-saving treatment, right? Like, why is somebody in Edmonton or Alberta getting something we can't get in British Columbia when we all live in the same beautiful country?
100%. And just to expand on that a little bit as well, it's sort of like on the take-home cancer drug side of things, we're talking about drugs that are already listed on the public formulary. And then when you're talking about innovation and what that patient had to pay privately, I'd speculate that's because it's not listed on a provincial drug formulary at that point. So then it gets into this space that a lot of patient organizations and cancer charities have been very active in, and that is accelerating provincial adoption and approval of innovative cancer drugs and precision medicine drugs, and having sort of consistent access to those drugs across Canada, across formularies. So it's both of those issues. On the private insurance, I really do find this fascinating because we do expect them, regardless of us solving those two issues and so many others, we still expect them to take on a lot of these costs and support patients. It'd be really interesting, I think, as a project, and Kathy, maybe we could continue to talk offline, but minimum standards for private insurers when it comes to cancer care in Canada and what that could look like, or if work's been done in that space.
Thank you so much for that. So this question is a two-parter. So what does financial toxicity look like for people living in remote communities and the territories? And can you speak more to the opportunities presented by hub and spoke models for rural and remote access to care?
Stephen, I'm going to leave this with you.
Okay, sure. I appreciate it. So for the territories, and not surprisingly, when we talk about costs, we're a lot of the time talking about costs of travel to, Kathy, as you said, sort of those centers of excellence that, travel to those appointments. And the costs of that travel, again, not surprisingly, is just, has a 10x factor compared to costs of travel anywhere else. There are programs available to alleviate those costs, but it's just such a high price tag when we're talking about the cost to territories. To the point around a hub and spoke model, I think we need to continue to invest in sort of what those innovative solutions might look like, what care can we deliver at community. In territories, it's always an additional layer of complexity because you're talking about a provincial system that's sort of partnered and delivering care in that territory, in a way that meets the needs of people in that territory. But I don't have I apologize. I don't have a lot to expand on as far as details on hub and spoke models, other than I think any way we could deliver more care at community ultimately reduces some of those, reduces for the patient, I should say, some of those large out-of-pocket costs. Now, it may increase costs to deliver that care from a health system perspective, but I think what we're talking about here is direct out-of-pocket costs to the patient, because either way, someone is paying for this care. And we'd like to see, on average, that 20% that's being borne by patients shift to other payers. So it is that conversation.
And Stephen, I know we're talking about financial toxicity, but we need to talk about emotional toxicity and outcomes for our patients that are having to leave their community of support. I just had to jump on a plane for a 2-hour flight to Edmonton, Alberta, and leave alone the financial toxicity. Emotionally, that last treatment, I went on my own. I didn't want to keep dragging my family out of their life to be part of it anymore. And that can have dire consequences. Because we had a patient that we helped get from Moncton to Toronto for treatment for a year. He became a very good friend, and he had decided at the last 6 months that he wasn't going to take a caregiver with him. It was, he had done it before. He got into the hotel. We lost him that night because he had a seizure. And his family to this day emotionally are beating themselves up because they didn't go. And so I think, with all the financial, the emotional outcomes, quality of life, it's all packaged together somehow. And I love that this is our panel discussion, but I think we can never forget, right, that again, my story had a good ending because I was not wealthy by any stretch, but I was able to find the resources, access resources, and get the resources I needed for a positive outcome. And I feel from the patients I hear from that still the majority of our patients are not getting even what I had. Their toxicity is truly parking in the hospital parking lot, right? So we can never forget, those incidentals for some patients, and those, especially our patients in the remote areas and those rural areas are really struggling.
100%, and the point you raise on caregivers is really well taken as well, because it's the sort of psychosocial support that caregivers provide. But we talked a lot about navigation and navigation challenges, and often it's the caregiver that's really supporting you through that navigation. That is your advocate. That's sort of looking at what reimbursements might be available, because as a patient, you're recovering from treatment. You may be experiencing symptoms like fatigue or nausea or things like that like may not allow you to stare at a computer screen for hours on end as you apply for tax credits or things like that. So I think the role of a caregiver is really integral to the experience, and it is that financial toxicity that adds a burden not just to patients but to caregivers. I mean, again, low-hanging fruit here is something as simple as making the caregiver tax credit refundable, so that more caregivers could use that support more often. It's something that already exists. And we're really advocating federally to make sure that it could exist to more people. So I think the caregiver piece is well taken. The travel on rural and remote, again and again, this is such an important point to underscore. When we look across the world, and we look at the out-of-pocket costs faced by people facing cancer in Canada, and then we sort of look at jurisdictions with universal health care, so basically excluding the United States in this. We are high compared to other jurisdictions with universal access, and a lot of that is because of the transportation costs. And it doesn't have to be this way. I think the average cost per patient in a jurisdiction like Australia is about $92 per month, whereas in Canada, I think the average cost is over 260. And in both those jurisdictions, you're talking about care that's delivered in a centralized way with vast distances to cover. But Canada is exponentially more expensive when we're talking about cost. So I think it's a unique Canadian problem and very much our problem to solve.
And we talk about, I'm sorry, and we talk about technology like everybody has access to that. And, we knew during COVID when we were trying to help patients understand how to virtually get on an appointment with their, doctor, that we still have a lot of patients that don't know technology, don't have technology. The patient in rural Manitoba that I was speaking about earlier, he literally goes to the office of the nurse navigator to have her communicate to me because he can't afford a cell phone. He can't afford technology. So there's still all of that too, right?
100%. And I totally agree with the technology comment. It's been an issue for quite a while. We're getting close to time, so I want to make sure we have a chance to answer our last question. I know we've been talking a lot about cancer, but as we know, living with chronic disease can also have a huge cost impact on individuals and families over time. So can you speak or provide insights or reflections for organizations who would like to start a program like Save Your Skin Foundation or other programs to help patients cover costs?
Well, first, I will start by saying it's not easy. When we decided during the COVID to do the taxi service, there was, I think, a group of 8 or 9 patient organizations that hadn't done financial distribution. You can talk about this. I'm a believer that if patients are reaching out to us for financial assistance, they need it. They fill out a form on the website. We kind of review them. I pick up the phone and call them, get to know them so that we kind of know a little bit about the patient that we're helping. We've been lucky, but we don't, like everybody right now, we don't have a lot of funding. We don't have as many resources as we could use. And we're starting to see the need from patients get greater and greater and greater. And so that's a concern we have. But I have to tell you, out of all the work we do, nothing's more fulfilling for me than helping a patient with their financial needs, because there was nobody to help us. And that could have, and that really would have helped us throughout this process. So.
And Kathy, you're the expert on building and running a program, so I won't even attempt to address that part of the question. And I really appreciate your response there. I think from my perspective, I'd also just highlight the work in the advocacy space that patient organizations do in cancer. It has a benefit on the patient space as a whole. If I look at the work I've been involved in over my past 6 years at CCS, the EI sickness benefit, that's not a support that's limited to cancer. When we talk about the extension to 26 weeks, job protected leave in the provinces to match that 26 weeks, again, isn't just limited to cancer. When I talk about making the caregiver tax credit refundable, that's not a specific cancer tax credit. That includes a number of disease groups. So I think, advocating together, but also acknowledging that the advocacy work done in the cancer space benefits a number of disease areas beyond just cancer. And I think that's really important and certainly a message we want to continue to take to governments.
Agreed.
Thank you so much for all of your answers and for your candid conversation. It's been wonderful. So I think we're done for the afternoon, and I want to thank you both so much, and I'll send it back to Leah.
Thank you so much, Kathy, Stephen, and Kim. The combination of your moving personal story, Kath, with the broader evidence base that both you and Stephen shared, create a really powerful case for change. And as was just acknowledged, I think we all know that financial toxicity is not an issue that is specific to cancers. And we certainly encourage all patient community members to really make the case and advocate on this critical topic as it specifically impacts your community. And please do leverage the work and the reporting that has been done by the Canadian Cancer Society if it helps you in making that case. Together, let's all advocate for that responsive, patient-centered healthcare that anticipates and reduces the financial toxicity through greater patient, caregiver, and family supports. Navigators, as mentioned, are a great first step, including connecting them with everything that already exists that they need in order to better serve their patient community. And let's do our best to support impacted patients and their loved ones to the best of our collective abilities in the interim as we are filling the gaps in the system. For those of you who were asking or who might be wondering, the summit is being recorded and the videos will be shared through Save Your Skin Foundation's YouTube channel after the event. All registrants will get an email once they are available online. So we're now heading into a break, a chance for everyone to refresh and stretch ourselves a little bit. So please return at 2:15 Eastern time zone. That's 3:15 on the East Coast or 3:30 on the Rock and 11:15 for our friends who are nearer to the Pacific Ocean. So see you again at 2:15 Eastern. Enjoy your break. Welcome back, everybody. I am so pleased to welcome you back to a session that builds on past summit conversations about homelessness and housing. This year, in the face of the continued homelessness and housing crisis across Canada, and within the context of our major trade and security partner threatening us economically and existentially, Canada has taken some preliminary steps forward on this file through the creation of Build Canada Homes. And I quote, a new federal agency that will build affordable housing at scale. Build Canada Homes aims to leverage public lands, offer flexible financial incentives, attract private capital, facilitate large portfolio projects, and support modern manufacturers to build the homes that Canadians need, end quote. Of course, supportive housing is even more complex than simply building housing infrastructure because different levels of government need to get out of their silos to work together and fund the infrastructure, plus the specialized human resources from health and social services that are required to support clients in stabilizing their lives. To help us explore these opportunities further, I'm so excited to introduce the moderator of our Scaling Supportive Housing panel, Erin Boudreau. She's the Executive Director of Mental Health Partners. In this position, Erin works to strengthen hospital-community collaboration, positioning MHP as a go-to resource for insights into the care of people with severe and persistent mental illness, and to support knowledge exchange across the sector. Erin's career reflects a deep commitment to community well-being, spanning child and youth mental health, youth homelessness, and services for individuals with serious mental illness. Over to you, Erin.
Thank you so much, Leah. Delighted to be here, privileged to be here. The panel we're about to hear obviously talks about supportive housing, which is a critical foundation for improving health outcomes and addressing the intersecting issues of homelessness, mental health, substance use, and income security. The panel will present supportive housing case studies, one in Toronto and others in diverse parts of Ontario. Attendees will gain insights into the opportunities for integrated service delivery, infrastructure, policy, and investment across health and social services to drive sustainable, scalable impact and advance equitable health outcomes. Our panelists today, we've got Frank Horn, who is the principal at Indigenous Solutions. Frank Horn, as mentioned, is the principal of his own consulting business, Indigenous Solutions, working on projects meeting community infrastructure needs. For 25 years, Frank has worked with Indigenous communities across Ontario and Quebec and understands firsthand the economic gap that cuts across all sectors. Building upon his experience in Indigenous housing and Indigenous broadband, He now works with trusted partners on innovative yet proven projects to positively impact Indigenous communities and drive their own economic futures forward. Frank is a proud Ganakayan from the sister communities of Ganakwe and Ganastake in Quebec, and has dedicated his professional career in volunteerism to Indigenous community, including raising over 1,000 hockey bags each year for Indigenous youth across Canada. And Mina Mawani, who will be joining her presentation, is pre-recorded, is the CEO of Dixon Hall. Mina leads one of Toronto's most vital multi-service organizations. Dixon Hall is a charitable agency dedicated to supporting vulnerable and marginalized communities through housing, shelter, employment, settlement, youth, and senior services. Under Mina's leadership, the organization has launched a community hub and training center, modernized operations, and strengthened partnerships with government, academia, and grassroots communities to drive lasting impact. Mina is widely recognized for her ability to navigate complexity, align stakeholders, and lead transformative change. An educator and thought leader, Mina has taught leadership and social sector management at the Schulich School of Business. Her contributions have earned her the Order of Ontario, the RBC Top 25 Canadian Immigrant Award, and recognition as one of Canada's top 100 most powerful women by WXN. And we also have an excellent contribution from Kwake Adams, a resident at 65 Dundas Street East, who will be sharing his experience via video. Thank you.
Hello, everyone, and thank you for including me in today's important conversation. I'm so sorry that I'm not able to join you in person, but I'm grateful for the opportunity to share Dixon Hall's perspective on how housing, health, and community care intersect, and why supportive housing must be part of the future of healthcare in Canada. At Dixon Hall, our work is grounded in a simple but powerful belief: housing is healthcare. When people have a safe, stable home, everything else becomes possible. Connection to primary care, improved mental health, better medication adherence, and the ability to rebuild one's life. This is the foundation of the Housing First philosophy, and it guides everything we do. For so many individuals, the lack of stable, deeply affordable housing remains the most significant barrier to safety, recovery, and long-term well-being. This year, we reached a major milestone with the opening of 65 Dundas Street East, a revitalized supportive housing building that now provides permanent homes for over 90 tenants. Once fully completed, the site will house 280 residents through a rent geared to income model, offering deeply affordable, stable housing for those who need it most. The tenants who live there have experienced chronic homelessness, trauma, and complex health challenges. For them, 65 Dundas offers more than a roof. It represents stability, dignity, and a path toward healing and hope. What makes 65 Dundas particularly meaningful is the strong partnership that brought it to life. Dixon Hall has worked closely with the City of Toronto, whose leadership and commitment to expanding supportive housing were essential to making this project possible. I want to acknowledge Valessa Feria, who is the Executive Director of Development Review at the City of Toronto, who is joining this conversation today. Her team's collaboration has ensured that developments like 65 Dundas Street East can move forward quickly and responsibly to meet urgent community needs. Inside the building, our integrated wraparound supports help residents connect to physical and mental health care, manage chronic conditions, and access harm reduction services, while maintaining the stability of a permanent home. By placing housing first and aligning supports to each resident's unique needs, we are already seeing improved health outcomes, increased consistency in care, and most importantly, renewed hope. Our on-site housing team works hand in hand with tenants, connecting them to primary and specialist care, supporting daily living, and helping them build the confidence and skills needed to thrive. We meet people where they are, without judgment, and walk beside them as they move toward recovery and independence. The results are clear. Tenants are experiencing greater stability, better health, and a stronger sense of belonging. Outcomes made possible because housing came first and the right supports followed. Your work, which includes everyone here, advocates, clinicians, researchers, policymakers, and people with lived experience, is driving the transformation of Canada's healthcare system. By pushing for innovation, equity, and patient-centered practices, you are redefining what effective, compassionate care can look like. At Dixon Hall, we are proud to stand with you in this effort. We remain committed to building communities where every person not only has a place to live, but a real opportunity to heal, grow, and thrive. Thank you for including me, and I wish you all a meaningful and impactful summit.
My name is Madam. I live at 565 down the street east. And I volunteer for the Senate Dixon Hall community for the food bank. I've been living here since 2001. I started out 4 years. I got here because I was working and I lost the job. I ended up the sheriff there and I stayed and finally I help out into getting after I created the actually public and I also public. I used to drink a lot or drugs and stuff like that. And they like to hang up at the I have stuff on that stuff. Could all go into depression. That's what made me the big. I just actually put I was right through that way and shit. I couldn't have a chance to go because I was in that time. I feel great and the people here great were very respectful. I gave thanks to Dixon Hall community program. They helped me a lot. In terms of having this student for 2 years. They take care of me for us 4 years. It's a great program. Help me solve staff are great. Either virus and finally, I get a posting to try to help everyone to check people. They're great too. And I feel like I'm very happy to be here.
Hello, everybody. Sewaguego. My name is Asnaina Frank Horn, and I'm here to share my experience, my perspective on housing and how it correlates with what we're talking about here at the summit: health and wellness, mental wellness, and all that. To give you a bit of a background of myself, I'm Mohawk, and my mom and dad are from the reservation, and I never grew up on the res myself, but I heard all the stories of what it's like to be on the reserve. And so I'm an urban Aboriginal. So when it came to work, play, and school, I was like everybody else in the city. But when I came home at home, I understood what it was like to be Mohawk and our stories and who we were before colonization, during the colonization period, how we were integral to what Canada became Canada. And those are stories I heard from my mom and dad over and over and over again. And I didn't realize how integrated it was, but I realized I took those stories into my adulthood and into my professional life. I've been working in community for 25 years. A good chunk of it was with the federal government in a variety of departments. I worked for Indigenous Service Canada, and I understood the machine of government, how it impacted and worked with First Nation communities, specifically on reserve. But then I also expanded from that, and that's where I began to start working with community directly. I first started working with residential school survivors within the city of downtown Toronto, and I came up front the impacts of colonization, residential schools, all that stuff, and the lasting legacy of that. and realized that it's a very complex issue. And I began to ask the question. I had to understand why, because it never affected my family directly, but I had to understand why. And so I did my own research, and I asked a larger question: what can I do about it? And it just so happened that a little bit later, I had the opportunity to be part of a panel to review applications for Indigenous housing in the city of Toronto. And that was my first experience working with that, taking government funds and trying to make an impact on the social side of things, specifically in Indigenous. And I realized this is what I like to do. I found my new passion. And that experience on my CV gave me the window into CMHC. And that's when I really began to thrive professionally, where I realized that I found my niche is working with community directly. And it impacted specifically in the big gap of housing. And my first 7 or 8 years was strictly on reserve. And I had a suite of programs that I worked with, but it was a lesson learned from a policy side of things, in lack of funding side of things. Also, there was observations as to what it's like in community and building trust. And when the trust was built, then they shared their concerns beyond housing. And I found that opportunity for them to share who they were and what's really happening in the community, that was an honor for me, for them to share that. And I tried my best to see what I can do for them. Eventually, my scope expanded off territory. CMHC was under, I don't know if people remember the National Housing Strategy, where the government of Canada looked into the housing crisis, and they created this thing called the NHS, National Housing Strategy. CMHC was given the mandate to roll that out. And there were some Indigenous specific program for that. And that gave me the first purview to look at things off the territory within the urban setting. And that changed my conversation. And it was a learning curve for me to understand what is capable off reserve and on reserve. But I realized that I couldn't do it myself, and I started to expand about finding partners, because in order to do impact, one person or organization can't do it themselves. And the programs that I was working with at CMHC, there was only so far that I can go. It had to bring in partners. And that forced me to develop my skill set and my network. But I really loved it and thrived. I was really thankful for that opportunity, because I had to get on the, walk the pavement, so to speak, and talk to anybody who might be a potential partner. And I eventually settled on the right people to kind of do something that's meaningful. And that's where I eventually landed. I stepped away from housing for a brief period, working for a telco on broadband infrastructure. But my passion has always been housing. And now that I'm doing my own thing, I do a few things, but what always comes back is housing. And more recently, I think it's shown in my bio, I'm an FNHP, which is a First Nation Housing Professional. And that designation is given by an organization called the FNHPA, which is the First Nation Housing Professional Association. And the FNHPA got some seed funding from Indigenous Service Canada, ISC or INAC, and CMHC, because what was pretty evident when it came to Indigenous First Nation housing was the housing staff were underfunded, there was lack of capacity, skills, and they just need something to help. And so a lot of people that have been working in that space said, we got to do something about it. And so they petitioned the government, and they got some seed money, and there's like 2 or 3 staff and a board. And then they've expanded we have 30 staff now. We have a full board where I'm the Ontario regional rep. And the mandate of this organization is to provide support for on-reserve housing staff and anybody else that feels housing is important on the territory. And we provide the supports that we can. And we're developing programs, what have you. So that's kept me quiet. I'm actually here in Saskatoon, we're having our national conference, and we're going to have over 400 delegates for the next 2 days. And it's all about Indigenous housing. And it's an opportunity to talk and network, but also identify and try and problem solve. And there's going to be some vendors and there's people that are trying to tackle this huge problem. So that's going to be pretty exciting. And actually, Build Canada Homes is going to be there as well, and they're going to be part of the keynote opening address for the conference. And I think they actually have a booth as well with some of their staff to be able to talk to them about what Canada's thinking now that they have Build Canada Homes. So that's going to be pretty interesting and potentially exciting. We'll see what happens there. So we have a picture right here of something that I've done that I'm part of, and I tried to pare it down to get. There's some information that I couldn't share because it's not available just yet, but I thought I'd share some of the stuff that is kind of think let you know what we're thinking. So it's a project in, let's call it the GTA, and the working title is Skatke or Dewarakos, which is gather. And the reason why we call it gather is today Toronto is the largest multi-ethnic. Everybody from all over the world comes and gathers in Toronto, and it's created a housing crisis. And I know there's a lot of organizations and governments trying to see what they can do. And so I'm working with a real estate development partner, and we're partnering with a First Nation community, and they are acquired a piece of land in the GTA, and it's a beautiful piece of land that kind of backs onto some wooded lots. So we'll integrate some natural landscapes to make it not so much of a concrete jungle. And we've included some Indigenous architects right now this is all preliminary. Once we get further down the road, we'll be able to kind of be a little more concrete as to what it looks like. But those are the concept drawings right there. And the model, when we approach different funders, it's reconciliation in action. Too many times, Indigenous communities we all hear reconciliation, the term. What does it actually mean? And the best way I heard about it from a project I did on a reserve here in Ontario, where it was a housing subdivision that met the need. The chief was quoted saying, "This brings reconciliation beyond the rhetoric. It's more than just words. It's actually action." And to many Indigenous communities, they're tired of just words. Beyond tired of just words, they want something that's meaningful to them. So I share that with my team, and how we need to approach this. Because I work with, real estate developer. He has the full suite of experience and knows how to navigate and underwrite and find the financing and funding and do all the pro formas, all the math all the numbers that you need to make sure a project is viable, and work through the construction phases. And he's willing to partner and offer that to First Nations so they have an equity stake in projects. And that's the model that we're approaching here. But what I said is, when we're approaching communities to bring them in, what we want is no longer decisions that are just made in the boardroom or the ivory tower and they're dictated to communities. It's collaboration. And First Nation communities, Indigenous communities are saying, the way you've dealt with us is no more. We are going to stand up and vocalize if your approach is wrong. And I think they're being heard, and there are progressive people within organizations that might be a little harder to move along, but there are people that are trying to do their best within the bureaucracies that they are. But that from the Indigenous side of things, they're saying, okay, we need action. And we're tired of just the words. So that's the approach that we have with the team I'm part of. It's reconciliation, but through housing specifically. And what we have is kind of a model. And I'll share high levels about what our model is about and how we approach funders and what it means to the end user, but also what we're trying to sell to Indigenous communities to bring them in, them being willing to be a partner beyond the territory. Can they do something within the urban setting as well? So that's kind of so what I do, I'm the Indigenous relations. I'm the guy that knows how to, I walk between two worlds. And so I'm able to kind of, based on who I am, where I come from, able to talk the res talk, so to speak, but I also know how to talk the corporate talk. And so depending on that, I make sure that everything is staying on path and that's just not a transaction, but it's meaningful to both sides. It's meaningful to the Indigenous community as well. Because if they trust me and I vet these partners, then we've made a lot of steps already down the road. So I'll just pass on to the next slide. So this basically this in the concept, there's what you see there is an atrium. It's kind of like an open area that will be beneficial for the tenants of this project. There's 2 towers on each side. There's going to be a number of units. It's going to be at least 300, and we're working to try and get more than that. But there's going to be a whole community there, and we're not just looking at it as a place to you live. It's going to be much more of a community, and we're thinking about. We're trying to think about be as inclusive of everything as possible, including spaces like this that be, and you can see we have Indigenous art, but there's going to be a lot of things that you can book this place for Indigenous specific events that are meaningful, but also non-Indigenous. But what will be pretty apparent through the design features, if you have an eye for it, you realize that there's Indigenous components woven through. And this will be talking points, education points to share that the Indigenous community of Canada, we're still around, and we're trying to do something meaningful for everybody that's come to this country here. So that's kind of the idea of this atrium area. So pass on to the next one. In terms of, I guess I try to pare down a few things here in terms of what we're trying to do. We still have some 4 pillars here of design concepts. And the first one is accessibility and intergenerational design within the Indigenous community and a lot of countries around the world. It's not so much, it's before we got westernized, so to speak, there was family units, clan systems, intergenerational. You had your elders, up to the young ones and everything else in between living. And so what we're trying to do is sometimes Indigenous families, or if they're on their own, they don't necessarily have the support system. Is there any way to design it so that they have a support system and ideally family within the same unit around? And that's kind of what we're trying to think about this when we're designing this concept. So it's a unit mix. So what we have here in terms of what we propose for funding and it's viable in terms of what we can bring in for revenue to offset our expenses is we're include as many 3-unit apartments, which is almost non-existent in Toronto for on the market. And the idea is to, when it comes to lease up and bringing this to potential people living there, the idea is to, it's not just a small family or a young urban professional that just needs one small space. This is the idea, is trying to create a space where as many people can be there and feel safe and integrated. And in terms of the affordability, we have some affordable, but then we also integrated some that are deeply affordable. And the rates that we're going to charge to the tenant are like, they're not what you can't, like these are rates from decades ago. And what we're trying to do is meet the need for as many Indigenous that would, well, anybody, but also Indigenous, to try and get as many of them in the deeply affordable, because that's, in terms of what we're talking about here, I would say, is deeply affordable is kind of the crux of it. And to be able to provide that support, there's a mix there. What's going to happen is there are revenue streams, including the market rent, is going to be able to be there's going to be enough revenue that subsidize deeply affordable as well, and that's kind of the idea of it. In terms of sustainability and goals, we're including the land. So it's kind of like there's going to be integration with the way it's designed. There's a lot. So basically, there's going to be a lot of pathways, and it won't so feel like a concrete jungle, so to speak, but it will be integrated with. It's kind of like there's the idea of the land saying, okay, there's the land. How do you? My brother's a golf course designer, and it's all about a beautiful golf course doesn't just carve out something, but it uses the land to be able to play golf, but also the natural contours of the land. Well, it's the same concept here, but it's a living space. You want to integrate it to be as inclusive of the land around it as possible, so that people feel like it's a place that they want to stay. In terms of architecture, we've worked with an Indigenous architect on this at the beginning stage, and we will include as much Indigenous as possible through the full design phase up to construction. And in terms of cultural inclusion, we are going to also include what we call an RSIC coordinator, a staff position. And the RSIC stands for Resident Service and Indigenous Coordinator. And this position, where we're able to fund that, is going to be separate from the property manager and the landlord. This person is there to ensure that Indigenous components are there on the daily living. So when people are, that person there'll be Indigenous people. It'll be advertised that there are Indigenous services from cultural aspects, things that we need to make sure that they feel at home. From that person will be rooted in culture, but providing they won't necessarily deal with the day-to-day maintenance. That's already set aside. This is to make sure there's added value in on-site supports from a cultural aspect, and that in itself can help with the mental healing that we're talking about today. So that's kind of what we're also including in our project. Next slide. So we have some commitments that we make. High level cultural reconnection. Toronto is it's very much concrete jungle. There's some green space, but not as much as we like. And what we're trying to do is Indigenous feel like when you go outside into the more rural areas, you get connected to the land. It just does something. Indigenous people feel that way. We're going to try and take as much of the nature and bring into this space. So there's a maybe a conscious or subconscious reconnection to land in terms of the living space. There's going to be equity inclusion. Now, it's not going to be Indigenous specific. It's not going to be all Indigenous in terms of who's going to be living there, but it's going to be very inclusive of the people from all over the world living there as well. But they will understand over time that this is going to be an Indigenous-owned project, and that they will have opportunities to understand the people that were here before. In terms of the design, we're including as much of it to be net zero, so as least harm to the environment as possible. And I can't speak to that. That's not my specialty, but we have people on the team that can definitely answer those questions on net zero design. And it helps on the operational side of things. And if you just do it right at the beginning in terms of construction. One of our pillars is wealth building. And the business partner, he is a real estate. He's got 25 years as a real estate developer. He started small and he's expanding. And we met through, men's hockey of all things. And over time, we exchanged phone numbers. And when he found out I was doing what I was doing with the government, he says, let's partner up one at a time. And now we're doing projects that's pretty exciting. And what he's taking is his real estate development skill set, and he's offering that because 35 years ago, he went to an Indigenous community in Northern Ontario, and he saw what it was like, and it really affected him. He goes, that was pretty impactful as to, he saw all the stuff that's pretty bad. And he goes, I don't know what do I do? When he met me, we talked, he goes, maybe what I can do is, my way to get back is how about I empower them so that they have a path to generational wealth, so that all the proceeds of this become back to the community from a dividends perspective. And the idea, we also committed to reconciliation action through housing. And that's the model here. Next one. Last thing I would say on this one is, you can, if you notice, there's some Indigenous stuff there. There's the circle there. That's going to be a spot for ceremonies, people to talking circles, what have you. And I didn't include a picture, but there's things from an aerial point of view that you can see that are very much Indigenous, and that's going to be woven in. And especially as we get down the process, what is a point of emphasis is as we're going to have as much input on the design phase to make sure it's inclusive of what they want in the final product. These are just concept. It'd probably be even more Indigenous, so to speak, when it's finally done and start leasing up. But what could this mean from a mental health standpoint? We have another, this model, what we're doing is a larger scale one. We did something very similar at a smaller scale and in a different city in Ontario. And when it came to lease up, also when it comes to the tenant selection policy, what we do is we create a board, so to speak, and the board has they have control as to what's included and not included. They're at the decision-making table, including who is going to be leasing up. And so first right of refusal, so to speak, would be the Indigenous community from this First Nation. They would have first option for anything if they're interested in living there. And it's not going to be necessarily something where they're going to be vetted to make sure that they're a good fit and they can, be able to provide the rent, even if deeply affordable. We'll make sure that there's all this. We work with the city to work with on getting subsidies available, whatever we can get in terms of stacking all the funding. We do that as well. But what that means to the end user, there's one example. There's one in the other city. The first person that was selected to bring in was a young lady who's like 35, mid 30s. And she was born, she's in a wheelchair, and her mom and dad did her best. She's Indigenous, and her mom and dad did their best for her. And she wanted to go to school, and she wanted to be independent. And in the area that she lived, she was on the waiting list for since she turned 18 till 35. So let's call it 17 years. And I don't know where she was on waiting list, but in 17 years, she was not going to get a place through the local county. And so when it came the opportunity for lease up for this other Indigenous project, because she's from that community, she wrote a letter, and it was a very touching letter as to what this would mean for her to live there. And so the committee that was reviewing this said, okay, she's not going to be our first one. We're going to highlight, if she's okay with that, as to her story, what it means to her. So we were there, and we built a studio apartment for her to be able to use to meet her needs in terms of a wheelchair with a shower, the kitchen, the whole bit. And so when it came to looking at the unit, which one she wanted, because there was a handful of ones, she had first dibs at which one she wanted. And I was there to see her reactions with her mom, and her mom was there to be with her, and her mom was super proud. And the daughter, well, she's not, the young lady, she was, she had a smile on her face. She was she's crying basically the whole time. And you could see the wheel turning, what this would mean to her, the independence that she craved ever since she was an adult, she couldn't have. And now this was the opportunity for her to have independence. And the location of this building was right on the bus route. So she could finally finish her schooling, be on the bus route to go to school, and she could be independent and do what she wants and do her grocery shopping, all the stuff like everybody else. And so when we heard that story, and then basically what we saw her mom was just very emotional as to what her daughter's dreams were finally met. And to me, that's what it could be. It's a pathway to provide the structures so that people can dream. And when it comes to mental health and what we're talking about, it's no different. Housing is that basic right, becomes a platform for everybody else to do what they want to do beyond that. So that's my little one example of what can be done. And it's different, because the one thing that's pretty apparent in this, it's quite expensive, and you have to be adept and learn how to be able to stack funding and figure out ways so that you meet all the funders' requirements, so that if you can do it in such a way to create stack funding, then the viability of the project is stronger, and therefore you're able to meet more of the needs of the community that need the affordable units as well. So that's my slide presentation, and we'll pass on for Q&A.
Thank you so much, Frank, for that incredibly insightful and thought-provoking presentation. Actually, just kind of picking up on, you've kind of alluded to some of this already in your presentation, but as question one, I have a few for you, obviously. What are the most important enablers and opportunities to scaling supportive housing across Canada, including not only the infrastructure, but also the needed staffing and human resources?
Scaling. I think my experience right now is it's easier in the large urban centers right now, honestly, because the density helps. Density has its own negative because there's lack of space. But the benefits of density is there's more people, there's more resources to access. And so what I shared with you is capable because it's in a more dense area. And so what I think what our secret sauce is we're able to tell a story as to what this can mean to the community. If you can tell a story that kind of sells the idea, the story can bring in the potential partners that you want. You don't want all partners, but what you're doing is attracting all the right potential partners to the table. Because if you present the story and package it just right, and if it aligns with their goals, you can bring a partner in. That to me is the way to scale. Because you can't really do it. It's not. You can do other ones, but I don't think you can do quite the scale as this one. You can do smaller versions of that in other settings. Small town. You probably even do smaller towns, but I don't have the experience just yet.
And with respect to bringing in partners too, one of the things that you mentioned in your presentation too was the importance of building trust. So when you're bringing partners to the table and collaborating, what are some of the key things that we can do to actually facilitate trust, to support the scaling of these solutions as well?
Trust? Yeah, well, that if you don't have trust, in the space I work, you have nothing really. And you can only really move at the speed of trust. You might want to go as faster, but in reality, if the trust is not there or you haven't built it up quite yet, or you have varying degrees of that trust, you can only go as fast. But it just takes time. From the partners at the table, there's kind of you feel each other out and see if there is alignment and that they all have the right capacity to do it. Do they have the skill set? Number one, you want the right people that have the right skill set and that are willing to do it for the right reasons. And that just takes time to vet that. Beyond that, Indigenous communities, there's a lot of people that they're there for the wrong reasons, and they just see the numbers that they're going to try and get their own real quick and then leave. And this can't be viewed as a transaction. It has to be viewed as a partnership and a relationship, and that we're going to go right from concept all the way through, and then even after it's done, there to offer supports even afterwards. If that's kind of the idea of it for everybody involved, then it can happen. But if there are people that are just there in there for a bit and then trying to get their own, well, those people or the organization their true colors will be revealed over time, I would say. But over time, in the end, if you get it to the end, more often than not, you got the right people to be able to do it.
And then in that same vein, because I believe one of your slides also spoke to cultural inclusion or inclusivity too, in the spirit of co-design and co-creating solutions, what are things that work well with that as well? Bringing people in, like to your point, end to end, basically. But how do we create a space where we can truly co-create by very definition together?
I think number one is I think that's the fun part, to be honest. There's a lot of stuff that are the minutia can be tedious and that's not fun, but it has to be done. But the idea to co-create and create something on a blank canvas and what is possible, that conversation, whether it's just like a visioning session or different stages like that, what you want to do is my experience is you create the company, the new co, and you build it's a GPLP, so general partner and limited partnership, and everybody has within that framework of the legal entity, you all have a say, and so nothing can't be done without that conversation being had, and you have control over which partners you bring in. And so when it comes to that, if they're all already, if the GPLP partnership, everybody that's there And what I didn't share, or I should have shared before, is in the GPLP partnership, when 51% of it has to be at least Indigenous in order to access some Indigenous funding. I've been one where it's much higher than 51, but in order to be Indigenous for funders, 49% in terms of the share within that NUCO. But on the decision-making side of things, to be inclusive and also, but if you have that and it's done properly, you have control mechanisms. Because when it comes to this stuff, because it can be expensive, you want to have control over the various places. And what I like about this is you're bringing in the Indigenous people at square one, so they have control over it right to the end. Okay, because too often than not, I've talked to organizations in the city of Toronto that are Indigenous, and they have real estate developers that come in and they pitch them an idea, say, we'll do this, we'll do that, and we'll leverage your name because you have a name within the city, but what we'll do is we'll give you 1 or 2 units at the end that you can use. And that's traditional what real estate development has done. And that's not trust building. What this is we're going to create an entity so you're part of the decision-making table, which is really a novel idea.
Well, and on that note too, well, this is kind of two-pronged. So in the spirit of scaling solutions and also in the spirit of co-creating solutions, what are the mistakes to be avoided?
Mistakes? Don't do it through the pandemic. I was part of it. I was part of a project that was 2 projects that was creating a lot of momentum, and it was going through, and they had fixed costs that they thought just before 2020 hit. And once we rolled in 2020, all of a sudden it just mushroomed and it couldn't be done. So in the end, one project took a 5-year hiatus and they got it, but they had to really take a stop, take a few steps back, rethink things that need to be done in terms of the costs, and go through another round of fundraising and stuff. But the other one, basically, this was a kind of the same idea where there was a number of First Nations that are partnering on the GPLP. Well, the conversations that were being had in 2019, that leadership was in place. Well, sometimes 3 years is a long time with the leadership. There's a new refresh. By the time things were coming out of the pandemic and re-engaging, it was a whole new leadership. And they basically backed out, said, you know what, that was the old regime. We don't want to be part of it. They handed the keys. So I guess, but that's beyond your control. Like that affected everybody, especially in the affordable housing space. So there's lessons learned that I would say is try and plan as much beforehand before you kind of get to the ready where you sign on for financing, and start make sure that you have thought about every scenario, every potential thing that could happen. Try and think it out through hand. And that's what I like about bringing this real estate developer, because he's got the scars from experience doing other projects that are non-Indigenous, and he's willing to share those best practices with an Indigenous partner. And so I think if you have someone like that that's willing to share that is gold in itself right there. That's gold.
Well, and mentioning like the continuity or lack thereof, because there's regime changes, etc. So outside, well, who are the key external stakeholders or decision makers that also need to be engaged through these processes too, outside of perhaps we would normally engage in this process, to ensure some level of continuity, even at like the bureaucratic level, if you will?
Great question.
I get one.
I don't know if I can answer that question. Yeah. Luckily, the ones I've worked on, a lot of this has happened after when the Liberal government came in, and there was a lot of government funds federally allocated to housing, well, Indigenous, that affect housing, and luckily that regime is still in place. And if it's conservative, then basically everything's up in the air, I would say. And so there's those regimes you always be cognizant of. But if it's going to be more like that, the question is, okay, how do you pivot? You got to figure out the new landscape and see if there's what's the new path. But we're not there yet. So we're still on this where there's still a commitment to Indigenous and housing. And so I know I'm always, whenever kind of try and follow what's happening in politics, my lens is, okay, how does it affect the Indigenous space? And, I'm not just in housing, but I'm in different areas. And those Indigenous community in various sectors are all wondering the exact same thing. So those things you can't control. So you just got to figure out when times change, what's the new way of doing business, so to speak. And hopefully you can do it in the under new regimes. When it comes to potential other funders at the table, selling them on the idea that for them to be willing, and always have them in the loop as you're going through a project, whether they're a government funder or corporation. Make sure that they're every every stage of the process they're included as needed. It's a lot of work, but you got to keep them in the loop so they feel part of it. And so at the end, when everybody's cutting the ribbon, everybody that was around that table will be super happy because they feel that they have a part of it. Because they're partners, you want to include them every such way and realize that they bring in value and that you got to honor their value that they bring to the table.
Okay, I myself have two more questions, and I know there's a few questions in the chat too. So I promise I won't belabor this any longer, but I've got two more. So number one, so again, talking about government and bureaucracy, et cetera. In your view, what are the government policies that impact housing, social housing, the acquisition of supportive housing and building it?
Well, on reserve, the big one is the Indian Act. Because of the legal structure of the land and how it's you can't get a traditional mortgage, that limits capital availability. And so that impediment makes it really, really hard. Then you're completely dependent for the most part on government funding, whatever that purse is available. And my experience is it's never growing. It's going like this. So therefore, the number of units that you can build based on that, it's harder. So that's the big impediment. So that's why I slogged it on reserve, and it's fun and it's hard and it's meaningful when you have a project, but it's smaller scale because it's just limited to what government funding is available. That's why I like doing this, because the potential to access capital is much larger because you're able to mortgage the land and get more traditional financing. And the good thing is, if you do it where you tick boxes from affordability and Indigenous and environmental, like the net zero, you're able to get better financing terms on this and some government grants as well.
Thank you. And my last question for you too is, one of the statistics that we use in my organization is 106,000 days of waiting for mental health supportive housing. That's in the Ontario context. What can patient and caregiver advocates, partners, and organizations do to help? What type of advocacy can we do? Where can we lend our voice, and how?
Yeah, great question. I would say number one is, are you asking for Indigenous specifically? How your mental health can help support Indigenous? Is that your question?
I think, and just overall.
Okay. Yeah. I would say be in the spaces where this conversation is being had. Number one, if you're not in the room, then you really can't say much. So whatever opportunities you have, whether it's conferences or political forums, be in that room as much as possible and get your voice on the record. Because then, my experience in another space in with CRTC, they are trying to make things better for Indigenous communities when it comes to broad spectrum, all this stuff. And CRT has said, we can only go what's based on the record. If you don't have it on the record, then we can't really action it. I don't think it's no different than what we're talking about here. Be in those spaces where your voice can be heard, and hopefully you're invited. If you have to bash in the door, I don't know. I don't know if you can do that, but yeah, because I know what I learned is being silent is not a way to go anymore. I was early on in my career, I was kind of shy and whatever, and I realized, okay, let it for the big thinkers, that people that have more sway. And I realized as I became more vocal, I realized if I'm speaking truth and from what I know based on facts from an indigenous perspective, I have power in what I'm saying, and it has effect. And I think that's for all of us. Speak your truth to whoever you can from an authentic voice, and you're speaking for, and speak for the people that can't speak for themselves. When you have that opportunity, if you hear anecdotes, share what you know that means it resonates with the community you're representing.
And be proactive, like go once, go often too. Not
Yes.
yeah, absolutely. Thank you so much. Sorry.
And speaking about trust, like if you're the voice, they realize, okay, he's the one that's speaking for us. You're building trust for the community you're representing as well. Yeah.
Right. Good point. That's the end of my questions for you, but now I have some from the audience. So one is a comment. So I'm going to read this if it's all right with you. So if you are currently in Saskatoon, the suggestion is you should speak to Chief Darcy Bear. He has been doing this type of thing on the Whitecap Reservation. So I'm not sure if you want to comment to that.
I'm meeting him in 2 hours for coffee.
Perfect. There you go. Asked and answered. The second question is approximately how many rejections did you have to face approximately how many rejections did you have to face before getting the partners and the funds required? And if you were to do this again from the start, what would be different in terms of connecting with partners and funds?
So because I'm a former CMHC, former insider for CMHC, I know the programs from the perspective of the program. So I have that already. So from that side of things, I know the people to talk to make sure that when you submit an application or you're submitting a project, it ticks all the boxes that are required to get it through. And that to me is because if you come in not realizing you're just submitting based on what you might see on the website, you might not get all the nuances that kind of get you through. And so one of the people that we have part of our team, she's an expert in that area. She's really, really good at understanding what a funder is saying on the website. And she's really good at talking to the right people before the deadline to make sure that whatever we're thinking is actually so have those conversations before you submit. That to me is key. Have we been denied? I would say yes, but it's based on availability of funding. But we've been pretty selective as to where we say allocate our resources because it takes a lot of time. And if we know it's worth it, then we'll do it. If not, because we're a small team and we only have so many hours in the day, so we have to pick and choose. And I just take some of my perspective as a former federal government employee. So, okay, you know what? This is worth it. Let's go here. If not, let's pause. So, but what's interesting is one of the communities that we work with is we're working on a project in Quebec and they're super excited. And then they gave us an opportunity to say, hey, Canada Post gave us there's a property in the city of Montreal and they're doing their Indigenous outreach to see if you're interested. And because of that trust we built, they gave us that letter, said, do you mind doing some due diligence representing us to see if it's worthwhile to do that property or not, basically, because Canada Post is giving it up. And we did. We were honored to do that. And we came back after 30 days and said, you know what, we gave our recommendation. And in the end, we said no, because there was better opportunities. So hopefully that answers the question.
Thank you. And tell us more about stacked funding and partnership development, including for both infrastructure and human resources. This is a two-parter. You've been able to build in smaller communities too in the past, like Saugeen First Nation, using different nonprofit partners. Are there any opportunities to make the case for their supportive housing needs as well? I can read that again too, because it's long.
Yeah. Yeah, do you mind repeating?
Yep, I'll do the first part. Tell us
Okay.
more about stacked funding and partnership development, including for both infrastructure and human resources.
Okay. Yeah, infrastructure is key. You can't, if you don't have the infrastructure, you can't build the house because everything else comes first before you do that. So I'm not on the infrastructure side of things. We work where their infrastructure is already put in place by, in this case, municipalities. So that a lot of times, sometimes the infrastructure has been like, it's areas that were 30, 40, 50 years ago was the hub of that urban area. And then because of it became derelict. Well, those are opportunities as well. And so that's kind of an opportunity. But the infrastructure is already in place because it was built a number of years ago. On the, I guess on the human resources side of things, are you referring to the development team, or are you referring to maintaining the facility after once it's built? Because
that's right.
Yeah, I would say like that's something that's consideration you have to do. And you have to factor in those costs beforehand and put it in your operational plan in terms of your O&M to make sure that you itemize that and you realize what's the value of that those services, and make sure you factor it in terms of the costs that are required.
And then the second part here is you've been able to build in smaller communities too in the past, like in Saugeen First Nation, using different nonprofit partners. Are there any opportunities to make the case for their supporting housing needs too?
I wasn't in Saugeen. I was in the neighboring community of Nawash, which is in that area. I don't know to answer that question. And I don't want to speak for Indigenous communities unless I talk to them first. And to me, that's the first step. And so I guess the best way to answer that question is I would, if they're willing to talk about it and see what they want to do, I will see if I have that, if I can be a partner, an extension of their housing department, extension of their economic development. Because that's what we do. We say we're not here with the answers. We want to be here to support you with the people that want to do this. We're an extension of your administration. So I think the best way to answer that question is have a conversation with whatever community is interested, and whether they want to do it on the territory or in the neighboring area around them.
Yeah, it's not all one size fits all. So absolutely. I have another question here as well. What type of partnerships and funding do you think we need to address significant gaps to supportive housing with mental health services, in particular for Indigenous focus models?
Mental health. Yeah. I'm not familiar with that space, so I don't necessarily know what is available, but I think, okay, so, but I'm not sure, I'm not opposed to doing that. So my approach would be, if we want to build a project, do a project where that's going to be a focus of the clientele that we're going to serve. When it comes to the service that you want to bring in, I would have to reach out to this network here and say, okay, this is what we're thinking. Who do we talk to? And you bring that team or individual in to say, okay, are we in the right track? Who do we want? What services are available as an initial stage? And then if there's gaps, try and fill in those gaps other ways as well. That's the way I would approach it. Because I'm not an expert in your space, but I realize if we want to serve it, we'd have to bring in people that have experience in that space to make sure that, and to benefit from their lessons learned, but also their successes, what's worked well.
Thank you. And I'm just going to do one last quick check. Nope, I think that is it for all of the questions. Do you have any final thoughts or anything else you'd like to address before we officially sign off?
No, I really enjoyed this.
To put you on the spot.
The reason why I said yes to this, I realized that when it comes to the summit, what you're focusing on, there's synergies between housing and your clientele. And what I've learned is housing is a basic need for everybody, including the people that we're talking to about here. And what I'm hopeful for is something that this model that I shared, where it's what we put forward is a sustainable model that somehow can benefit your clientele. And because there's a way to do it, and you don't have to really, necessarily wait and hopefully that you get all the funding from the traditional sense, right? What you want to do, because if you can stack it and do this model, there's maybe a way to kind of meet your client's needs as well.
Well, thank you very much for your expertise, leadership, and time. And certainly, I think it goes without saying, like, we're stronger together and doing advocacy together, communities coming together to build more housing and get more supports in place. So thank you very much. That ends it for both of us. And I'm going to turn it back over to Leah to take us to the next step.
Thank you so much, Erin, Asnayando, excuse me if I mispronounced that, Frank, and Mina. These examples and this conversation were so incredibly inspiring, and I just want to encourage all of us to continue working together towards advocating for these types of supportive and affordable housing projects where they're needed in our communities in order to reach all of our neighbors that need more than just housing, but also need the affordability piece and the wraparound supports within a home in order to begin their path to health and well-being. Now we're moving into our breakout sessions to help us all digest what we've learned today. A big part of what makes this event different is our emphasis on engagement and action. So the themes of what you shared today in your breakouts and tomorrow at the end of our day in breakouts, those themes are really going to help guide our patient and caregiver dialogue on the third day of the event as we work together to form an action plan for the coming year. Don't worry, all the data that you share will remain totally anonymous. We will never share your name or other identifiable information. We really just want your great ideas and the themes coming out of your conversations. So please do join a breakout room and share your thoughts on what you've been learning thus far. So first, a few instructions. Hopefully this is really straightforward for everybody. If you are a patient or caregiver or a representative from a patient or caregiver group or an engaged citizen group, please choose any general discussion room. A facilitator is assigned to your room and will guide your dialogue. Please start with the lower numbered rooms. We planned for more people than we probably need. So all you need to do is click on the breakout rooms button that is below the video window, and then you'll select the breakout room on the following page. So again, start with the lower numbers, somewhere in sort of 2 to 10 or 2 to 11. And please glance at the participant numbers when you join the room. Help us balance the patient and caregiver groups by avoiding rooms that are already really full. So if you get into a room and there's 15 people in there, please go back and select a different room number so that we're really aiming for about 5 to 10 people in each of the general discussion rooms. If you do not identify as a patient or caregiver or patient group representative, please join the observers and allies room. And so I think we're good. Let's hope that this works. Follow the breakout room link that should be at the bottom of your video window. Select the room you'd like to go to. Keep doing that until you're in a room with 5 to 10 other patients, caregivers, or if you're an observer and ally, go to the room that's named Observers and Allies. Thank you so much, everybody. See you in a breakout room.